Remember to share the live as well. That would be nice. Renorta, I see you. Renorta. Put this over that side. How are you doing? I'll put this one up like this. Okay. I'm missing one thing. A microphone. Am I loud enough? I think I'm loud enough though. Okay, good. Hi everyone. Morning. Or good night. So this is a problem. This is a problem sometimes with Jamaican people. Them always I run late. You understand? Always I run late. I'm so sorry. I am so sorry. But I am here. I am here. Not too late though. Alright. Good night, Marvin. Welcome. Watchman. Welcome, welcome. Alright. So, and one last thing. Get this thing connected. There's so much connection going on here. Yeah. Alright. And then I'm gonna turn on this thing. Okie dokie. Yeah, welcome, welcome, welcome everybody. Asa. Forest, forever bless you early. Nice, nice. Daniel Love. Hola, hola everybody. Kayla was here bright and early as usual. Alright, so tonight I say we're gonna try to do a lot of cardiovascular questions. So we'll try to do cardiovascular questions, a little bit of pharmacology, you know, med surge. We'll do a little bit of a geriatrics, things like that. A mixture of every section of the exam, but it's gonna be mostly cardiovascular. All right. I'm doing well, Asa. How are you doing? Carousel, welcome. Can we talk? Sure, go ahead and talk. Put your message down there, Asa. Charlene, good morning to you too. How are you doing? Okay, so try to see if we can cover about 100 questions as much as possible. Thank you guys on YT for tuning in as well. I don't know, I'm gonna do this thing where I try to make sure I'm looking at you guys coming on jealous over this side. You understand? So I will be looking on both screens, okay? So bear with me. All right, but remember the rule of the game. You just put A, B, C, D, one of the answer. Remember, these are your patients. They're in front of you. So you have to do something. So you have to choose the answer. Deal? Allow the Lord to use you. Not a problem. You can be a blessing. Not a problem. Definitely, Asa. All right, so that's what we're going to be doing. So the areas are going to be from, let me tell you. So we have cardiovascular fundamentals, assessment, and what else? As I say, you'll have a little bit of med surge. So a mixture. So it's all cardiovascular questions. So it might sound alike, but at the end of the day, we're studying together. All right, and that's the most important thing. So, oh, one more thing. I think I missed my one book. I wanted to bring up a book. Oh, I use this one. All right. So let's start. I'm from Jamaica originally. I am from Jamaica. All right, so we're gonna start off with our first set of questions. All right. Thank you guys. So we're starting off with the first question. So while assessing a client, oh, just give the video a thumbs up. Let's go up to 1,000 just to say that, you know, you're with me. So just kind of tap up the live. All right. Hi, Curtis. Yeah, tap up the live. Let me know that you guys are ready to rumble. Let me kind of turn on the fan because I'm hot. Not too far though. Yeah. Let me know that you guys are ready to rumble. Okay. All right. Yeah. We're almost there. 1,000. Nice. All right. So the first one, while assessing a client, the nurse notes an irregular pulse. What is the best next step? A, count the radial pulse for 30 seconds. B, auscultate the apical pulse for 60 seconds. C, ask the client if he or she feels palpitations. D, notify the provider immediately. So you have a patient that is having irregular pulse. What is the best next step? All right. Are you going to count the radial pulse for 30 seconds? Auscultate the apical pulse for 60 seconds. Ask the client if he or she feels palpitations. Or D, notify the provider immediately. What's your best answer? Greetings from Turkey. Hi. All right. Remember, you have the patient in front of you. You have to do something. All right. Or else you're going to lose your license. Or the patient is going to die. So try to choose an answer. All right. Live shines at TJ. Welcome. Carousel. Welcome. So BA. Okay. All right, so B is actually the answer. Live shines. Good evening. All right, so auscultate the apical pulse for 60 seconds. All right, why not the radial pulse? Why you want to check the radial pulse? Why you decide to go with the apical pulse? Live shines. Hi, Unbroken. You said 30, you need 60 seconds, definitely. And then the radial pulse will probably be a little bit weaker, so you probably not be as accurate as the apical pulse. So definitely always go with the apical pulse when you're trying to check for, you know, accuracy with your heart rate. All right, so it says the apical pulse should be auscultated for 60 seconds to accurately determine rate and rhythm when an irregularity is noted. And it's the heart is strong, but yes, definitely. All right, so always go with your apical pulse. Asking the client if he or she feels palpitations, that's fine. You can always ask them, but what is the best thing for you to do at that time? You want to confirm. So you want to further assess your patient, make sure that the rate that you're getting, the rhythm is correct. All right, so you definitely go with your apical pulse and always go for 60 seconds. And especially when you're doing pediatrics, you're checking any pediatric patient, always do your respiratory rate as well as your heart rate. If you're doing your, you know, your assessment, always go for your 60 seconds with them. All right. A client reports chest pain. Which description most suggests myocardial ischemia? And we know that myocardial ischemia is the same thing as what? Quick question. Sure, Unbroken, go ahead. All right, so when you have your poor perfusion to your myocardium, you tend to have what? We're talking about your MI. All right, so when you have poor perfusion going to your heart, we're talking about your heart attacks there. So client reports chest pain. Which description most suggests myocardial ischemia? A, sharp pain on deep inspiration. B, crushing substernal pain radiating to the left arm. C, localized pinpoint tenderness. D, epigastric pain relieved by antacids. So a client reports chest pain. Which description most suggests myocardial ischemia? Is it A, sharp pain on deep inspiration, B, crushing substernal pain radiating to the left arm, C, localized pinpoint tenderness, or D, epigastric pain relieved by antacids? So you have a patient that is reporting chest pain and you're thinking about myocardial ischemia. Which description you're thinking of? So we have Asante says B, A, Shanitations. Okay, so B is the correct answer. So crushing substernal pain radiating to the left arm. All right, so most of the time you'll hear the patient say that they're having this crushing chest pain, or they feel as though a heavy elephant is sitting on their chest. They might have the jaw pain, the arm pain, nausea. They can have the epigastric discomfort, but you know, most of the time you're thinking about the substernal pain as well as the arm pain, all right, when you're thinking about myocardial ischemia. So the classic ischemic pain is pressure-like or crushing, substernal, and radiates in the jaw, the neck, and the left arm. All right, so anytime you hear a patient saying any of those things, always think about the heart, all right? What is sharp pain on deep inspiration called? So if a patient that is breathing in and out, or breathing in, and they're having, like, you know, pain in the chest when they're breathing in, what is that called? All right, let's look up costochondritis. Have you ever heard about costochondritis? All right, let's look up that. And so why am I not remembering my password? Let's go again. All right, so all right, so costochondritis is the inflammation of the cartilage that connects your ribs to your breastbone, causing sharp or aching chest pain that worsens with breathing, worsens with movement and deep breaths. So a lot of times when I hear patients says that they're breathing in and they're having the discomfort in their chest, you know, that is costochondritis as well. Sometimes if you press on their chest, they tend to tell you it's tender as well. It's the same thing. Epigastric pain relieved by antacids. What are we thinking about there? So if the patient is having epigastric discomfort, because we know epigastric discomfort is also, you know, for females, a lot of times we tend to be reporting that we're having, or for elderly patients, they'll say that they're having epigastric discomfort. You know, they can be having a heart attack as well. So you have to be careful with those patients. So if epigastric is, pain is there and it's relieved by your antacid, yes, and Asante, it is related to GERD, all right, your reflux disease, okay? So your answer there, a chest pain, patient having chest pain, which description most suggests myocardial ischemia, is going to be the crushing substernal pain radiating to the left arm, all right? The nurse hears a harsh systolic murmur at the right second intercostal space radiating to the carotid arteries. Which finding is most consistent with? Oh, this finding is most consistent with. So you have to know your different kind of murmurs. Your different murmurs. I don't know if how many persons will know this one. So you have A, aortic stenosis, B, mitral regurgitation, C, aortic regurgitation, or D, mitral stenosis. So a nurse hears a harsh systolic murmur at the right second intercostal space radiating to the carotid arteries. This finding is most consistent with, Junior says C. So the answers are A, aortic stenosis, B, mitral regurgitation, C, aortic regurgitation, or D, mitral stenosis. Charlene says C, which is aortic regurgitation. The answer is actually A, aortic stenosis. That produces a crescendo, decrescendo, systolic murmur, best heard at the right upper sternal border and often radiates to the carotids. All right. So I think there is a way for you to remember. Just go online and look up, like, you know, the different heart zones, and then you'll be able to picture it. Use YT as well, those videos, and look at the different murmurs, and they will tell you where you'll hear what. All right. And then you'll be able to better identify it. All right. Which assessment finding is most characteristic of left-sided heart failure? All right. Is it A, peripheral edema, B, jugular venous distension, C, bibasilar crackles, or D, hepatomegaly? So if a patient that is having a left-sided heart failure, how will you know that that patient is having left-sided heart failure and not right-sided? C, Asante says C, basilar crackles. Okay, do we have anybody else? Hello. I need one more answer before we move on. Just one. Remember, you have the patient at the bedside, all right? Your patient is dying. All right, so Charlene says C, so the answer yes is C. Why you say C? Why not right? What is, when you have a patient that has left-sided heart failure, what is happening there? If you have the left side of the heart, you know, failing, what is going to happen with the blood and everything? Or the patient tends to have what kind of, like, you know, signs or symptoms? The lungs are involved, yes. All right, so there is, so you have, let me pull up something. So when you have the right side of the heart, oxygen get low, sound get louder, definitely. But with the left side, you tend to have the lungs being, just think of it, look at the heart and just think of it. The left side is not working. So you're gonna have the fluids being congested in the lungs itself, all right? So you tend to have your crackles, all right? So definitely you wanna make sure that you have a better idea of that. So let me pull up something here. I'm trying to, there is a mnemonic where you can actually, hold on. And then when it's right-sided, they tend to have like a pedal edema and all of those things going on. Okay. So the answer, yes, is the left-sided that causes pulmonary congestion. So you have the crackles, orthopnea, and all of that. I'm trying to pull up something here for the two types. So with the left-sided, you have the fluid buildup in the lungs. Right-sided, it builds up in the body. So you tend to have like the lower extremity swelling. So with the left-sided heart failure, the ventricles can't pump enough blood to the body. The fluid builds up in the blood vessels from the lungs, leading to symptoms of shortness of breath, coughing, especially with exertion. And then with the right side, this occurs when the right ventricle is too weak to pump enough blood to the lungs. It often develops as a result of left-sided heart failure. So you have the fluid back up, causing swelling in the abdomen, the legs, as well as in the feet. All right. I think there was like an acronym for you to remember both of them. All right, so the peripheral edema would be for the right side, the right-sided heart failure. Jugular venous distension will be for the right-sided heart failure. Hepatomegaly will also be for the right-sided heart failure. All right. A client presents with cool, pale extremities and delayed capillary refill. The nurse recognizes these signs as A, increased cardiac output. B, decreased peripheral perfusion. C, normal findings in older adults. D, venous congestion. So you have a patient that presents with cool, pale extremities and delayed capillary refill. The nurse recognizes these as A, increased cardiac output. B, decreased peripheral perfusion. C, normal findings in older adults. D, venous congestion. So Kayla says B, definitely decreased perfusion, all right? So you have cool, pale extremities with delayed capillary refill, usually reflect inadequate perfusion, often due to decreased cardiac output. All right, if you're having increased cardiac output, that's not gonna happen. You're gonna have pink, you know, the capillary refill is gonna be quick and it's gonna be pink. Normal findings that would have been, and the venous congestion is not, you know, it's not anything that is gonna be delayed in terms of the capillary refill. So if you have pale, cool extremities, delayed capillary refill, that is because you have poor perfusion taking place, all right? A patient's blood pressure is 118/72. Yes, Raquel, welcome. A patient's blood pressure is 118/72 and in the right arm and 98/60 in the left. What should the nurse do first? A, document the findings as normal. B, repeat blood pressure measurements in both arms. C, place the patient in Trendelenburg position. Or D, notify the provider immediately without recheck. So you have a patient that is you're taking care of and you realize that the blood pressure on the left is, or the right is 118/72. The blood pressure on the left is 98/60. What should the nurse do first? A, document the findings as normal. B, repeat the blood pressure findings, measurements in both arms. C, place the patient in Trendelenburg position. Or D, notify the provider immediately. All right, so the answer is actually B. Yes, B. So you want to repeat the blood pressure measurements in both arms, all right? And why you don't want to repeat the blood pressure in both arms? Those are normal, like, you know, normal blood pressure reading. So why would you repeat the blood pressure in both arms before you do anything else? Because of the difference, all right, because of the difference in the systolic blood pressure or the blood pressure readings itself. So usually blood pressure differences greater than 10 to 15 millimeters of mercury between arms can suggest vascular disease. And so you want to confirm that by repeating the blood pressure before escalating. All right, so you always want to make sure that there is no significant change. So if it is 10 to 15 millimeters of mercury in difference in the blood pressure check, then that is something that you would be, you know, needing to address. All right. Document findings as normal. As I said, they're normal blood pressure readings, but because they're in the same patient, that is a problem. So you want to make sure that the numbers are, you know, close together, or at least less than the 10, you know, less than the 10 millimeters of mercury in difference. Placing the patient in Trendelenburg position. Usually you'll do that if the patient is, like, say, symptomatic, as well as if the blood pressure is severely low, then you'll do that to help with, you know, blood flow. And then notify the provider immediately. You definitely want to go ahead and recheck the blood pressure. If it is, you know, concerning, then you go ahead and notify your provider. All right. An S3 heart sound in an older adult most often indicates A, normal aging. B, pulmonary embolism. C, ventricular volume overload or heart failure. D, mitral valve stenosis. So an S3 heart sound in an older adult most often indicates A, normal aging, B, pulmonary embolism, C, ventricular volume overload or heart failure, D, mitral valve stenosis. Melissa says C, ventricular overload or heart failure. Do we have anybody else? Asante was says C. All right, so yes, so the answer is C, ventricular volume overload or heart failure. S3 is associated with fluid overload and poor ventricular compliance, often seen in patients with CHF or congested heart failure. All right. Let me pull up something here. I guess I can't use that one. Okay, and then you have your aortic. Is it aortic? What are we looking at again? S3. No, let's look at the heart zones. I think I needed that one. So normally we will be listening, and we always say, oh, we hear S1 and S2, but most of the time we're not listening for S3. But remember, for your elderly patient, you want to make sure you're checking for your S3 or your heart zones in general to make sure, you know, you're not hearing anything that is indicating hypertension or heart failure, things like that. All right. So S1, so the normal heart zones are your S1, which is a lobe. And this is the first heart zone caused by the closing of the tricuspid and the mitral valves at the beginning of the ventricular contraction, which is a systole. All right. S2 is the dub, and this is the second heart zone created by the closing of the aortic and the pulmonary valves at the beginning of ventricular relaxation, which is a diastole. So S1 is when you normally hear, because it is the closing of the tricuspid and the mitral valves. All right, and then you hear S2, which is the closing of the aortic and the pulmonary valves at the beginning of ventricular relaxation, which is diastole. All right, S3 is an abnormal heart zone, and it is an early diastolic zone caused by turbulent blood flow as the ventricles rapidly fill with blood, often seen in conditions like heart failure or dilated cardiomyopathy. And S4 is a late diastolic sound heard just before S1, caused by a forceful atrial contraction pushing against a stiff, non-compliant ventricle. All right. So always try to remember that one. So Kayla is asking, why is S3 normal in younger adults? I remember that one is, let me just look up. I remember that one is pretty normal in younger adults. Let me look up something here. Can't remember. Okay, so it says it represents rapid ventricular filling. All right. So, but if it is in the older adults, then it is abnormal. So especially in athletes, persons tend to have S3, but it typically becomes inaudible with age, usually disappearing after age 35 to 40. All right, so it's because of the rapid ventricular filling, you know, for the younger adults, why it is normal or why it is heard, based on what I'm hearing or reading here. But I remember, yes, that is something that is pretty common in younger folks. And as you get older, then if it is still there, then that is something that is concerning. All right. So, and then you have to remember with the younger, you know, the younger folks, the heart ventricles are a little bit more, you know, flexible, you know, elasticity is there. So you tend to have high velocity of the blood, you know, entering as well. All right. So it can also be normal in athletes due to increased blood volume. All right. So yes, but anytime you hear it present after, like, you know, age 35, 40, then you have to investigate it. All right. So as I say, pathological S3s are linked to heart failure, ventricular dysfunction, or volume overload where the ventricle is stretched and overfill. Can also be a sign of conditions such as your myocardial ischemia or dilated cardiomyopathy or acute valvular regurgitation. All right. So we said the S heart zone in an older adult most often indicates ventricular volume overload or heart failure. All right. And that is something that is due to fluid overload, poor ventricular compliance, often seen in CHFers. All right. To best hear mitral valve sounds, the nurse should place the client in which position? A, supine. B, sitting upright, leaning forward. C, left lateral decubitus. Or D, prone. So you have a patient and you're trying to hear the mitral valve sounds. The nurse should place the client in which position? A, supine. B, sitting upright, leaning forward. C, left lateral decubitus. Or D, prone. Charlene says B, which is the sitting upright, lean forward. Do we have anybody else? Melissa says C, left lateral decubitus. All right, so left lateral decubitus is the answer because this brings the left ventricle closer to the chest wall, enhancing mitral sounds. All right. So if you want to hear the mitral valve sounds, then you have to put the patient in the left lateral decubitus position. All right. Pre-testing teaching for an exercise stress test. Exercise stress test should include A, take all medications, all heart medications before the test. B, avoid caffeine and smoking the day before the test. C, fast for 12 hours before the test. Or D, expect to lie flat during the test. So pre-test teaching for an exercise stress test should include A, take all heart medications before the test. B, avoid caffeine and smoking the day of the test. C, fast for 12 hours before the test. Or D, expect to lie flat during the test. So we have BBB, Dorian, welcome. Thank you, Jesse, welcome, welcome. Holy File, welcome. So B is the answer, caffeine, avoid caffeine and smoking the day of the test. Why you want to tell your patients not to smoke or why they're not supposed to drink, you know, their 6 cups of coffee before coming for their stress test. Why you don't want to do that? Increases cardiac risk. It's a stimulant, definitely. So it's a stimulant. So they're already going to do a stress test. They're going to put the heart under a little bit of a stressful event there. So you don't want to give them anything else that will alter the results for your test. All right. So definitely encourage your patient to avoid caffeine and smoking because it might affect the heart rate and may alter the test results. Comfortable clothing is also recommended. Take all heart medications before the test. Is that something that you would encourage them to go ahead and do? Fast for 12 hours before the test. Is that something that you'll tell them to do? Expect to lie flat during the test. So I don't think they're going to be lying flat for the test. All right. Most of the time they're going to be going on a like a treadmill and be doing, you know, some exercise. Fast for 12 hours before the test, you know. I don't know if they really need to fast for 12 hours. Can you imagine telling somebody, you know, to fast for 12 hours before the test and then they're going to try to run before the test? So I don't know if that is something, you know, I think they probably can eat something light before the test. Take all the heart medications before the test. You want to make sure that they go ahead and take their medications. All right. Tall peak T waves on an EKG. That would void the test. Erin and Jagger. We're talking about the caffeine. You're talking about the caffeine and the smoking. Erin. Thank you, Jesse. Oh, yeah. Definitely. All right, tall peak T waves on ECG suggest A, hypokalemia, B, hyperkalemia, C, hypocalcemia, D, hypermagnesemia. So you have an EKG and you notice that there are peak T wave. What are you thinking about? Is it A, hypokalemia, B, hyperkalemia, C, hypocalcemia, or D, hypermagnesemia? So we have Asante, B, yes, hyperkalemia. With the, what is hypokalemia with a K? What are we thinking? What is hyperkalemia? U wave. No, what is hyperkalemia? What is, not sure. No, as in like low potassium, high potassium, that kind of thing I'm asking, sorry. Because you know, sometimes we still get it a little bit confused. So high potassium, okay, nice, yeah. And then the hypokalemia would be the low potassium, hypocalcemia, a low calcium, and hypermagnesemia would be high magnesium level. All right. For hypokalemia, we're thinking that the T waves would be depressed. Because most of the time. So that in hypokalemia, the T waves will be depressed. Let's see what in hypomagnesemia. So the hypomagnesemia, what would be happening with that one? So you can have several EKG changes, including lengthened QT interval, ST segment depression, peaked or flattened T waves, prominent U waves, and prolonged PR interval. All right, that's for the hypomagnesemia. And then for the hypocalcemia, for the hypocalcemia, you will have the QTC prolongation due to ST segment lengthening. All right, so you have to look at the QTC on your EKG there, because they're gonna be prolonged. All right, so okay. So if you have a patient that is on furosemide, what are you expecting in terms of, like, you know, their labs? What is one lab value that you will be keeping a close eye on? Or one or two of them? What are some of the lab values you'll be keeping an eye on for your patient with potassium? With yes, with furosemide, you're definitely gonna be keeping an eye on your potassium. Good morning, Sparks. How are you? Keep an eye on your potassium, because you know that, you know, with the furosemide, you lose your potassium. All right, so you want to keep an eye on that. When you have a patient that is hyperkalemic, you want to do what? What are some things you definitely want to do for that patient when you are having that patient that is having, you know, those peak T waves? What are some things you want to definitely do because of the risk for arrhythmia? Thank you. Check your EKG, connect your patient to the cardiac monitor, things like those. All right, because of the risk for arrhythmias, you want to make sure that that patient is connected and you can identify any changes. All right, that is going on. Monitor your arrhythmias, definitely. So hyperkalemia produces tall peak T waves and may progress to arrhythmia. So those patients, you want to keep a close eye on them, just like all of the other patients them, but you know, the hyperkalemia is something that definitely you want to keep an eye on with your arrhythmias. All right, which lab is the most specific marker for myocardial infarction? All right, and we're talking about your heart attack here. So which lab is the most specific marker for myocardial infarction? Is it A, your CKMB? You have B, which is troponin, C, myoglobin, D, BNP. So which lab is most specific for your myocardial infarction? Okay, so we have B, troponin, definitely. That is when, what happens when you notice that you have, you know, your troponin in your blood? You're thinking about your muscle, your heart muscle. So for example, you have a patient that is a renal patient, or a patient that has rhabdo, and you go ahead and check for, you know, you're checking for your troponin. Or how would you differentiate between, you know, the patient that has rhabdo or is having heart attack? What test would you be looking for? Would you be looking at your CK, MB, your troponin, your myoglobin, or your BNP? What test would you be looking for to differentiate? Because the troponin can be elevated, but it doesn't necessarily mean that you're having a heart attack. Because you can be having muscle breakdown. You might be having muscle breakdown because of, you know, you have your rhabdo, or you might have your kidney problems. You might have renal. So definitely myoglobin, yes. I hope I hope I say it properly. But yeah, your myoglobin definitely you want to be looking at. You also can look at your CKMB, all right, which is your creatinine kinase, your CKMB, all right, blood test, all right. So this is your test that measures your enzyme. So it's an enzyme that is released in the blood when there is damage to heart muscle. Once a primary test for heart attack, it's largely replaced by your cardiac troponin tests, which are more specific and sensitive. All right, so the specific one is your troponin, but your CKMB, sometimes the C probably providers order that one, but the best one is your troponin, because that one is more sensitive to your heart muscle or for myocardial injury. All right, your myoglobin you can look for in your rhabdo patients. All right, you can check. So for example, you see a patient and they have the dark urine, they have been in the sun, and you want to know what is happening. You can check your, you know, your myoglobin on that patient. For BNP, who would you normally check your BNP on? So who you normally check BNP on? So your brain natriuretic peptide, BNP, is usually on your heart failure patient, all right? Your CHFers, yes. So you normally check that one, because with the hormone, once it is released in the heart, usually the heart is working harder. And so usually you do this test and be able to tell if they're having heart failure or how bad their heart failure is. All right, so the troponin is the one that is most sensitive to your myocardial infarction. BNP is for your CHFers, your myoglobin is for your muscle. So you're thinking about like a rhabdo, you know, rhabdomyolysis. Is rhabdo, R-H-A, your rhabdomyolysis, then you think about that one. Your CKMB you can also use for your heart attack patient, but that one is not as sensitive as your troponin. All right. Alternating strong and weak peripheral pulses are documented as A, pulsus paradoxus, B, pulsus alternans, C, bounding pulse, or D, thready pulse. So alternating strong and weak peripheral pulses are documented as A, pulsus paradoxus, B, pulsus alternans, C, bounding pulse, or D, thready pulse. So alternating strong and weak peripheral pulses. A, pulsus paradoxus, okay. Do we have anybody else? A, Dorian says A. The answer is actually B, pulsus alternans. All right, let's look that up. Alternans. All right, so I guess we're gonna use alternance to say alternate. All right, so pulsus alternans, we're gonna say use alternate to help with remembering that one. So pulsus alternans is alternating strong and weak peripheral pulses. All right. So it is a clinical sign of heart dysfunction where there is regular pulse but with alternating beats of strong and weak force. All right, and this is diagnosed by feeling the arterial pulse and confirmed with a blood pressure cuff, where alternating loud and soft coracough sounds are heard as it's usually deflated. Then you hear your pulsus paradoxus. Usually that one is abnormally a large drop in your systolic blood pressure, more than 10 millimeters of mercury during inspiration. And it is a symptom of an underlying condition, not a disease itself. It is often a sign of cardiac tamponade, a condition where fluid buildup in the pericardial sac compresses the heart, all right? It can also indicate severe asthma or other respiratory issues, constrictive pericarditis, and other conditions that affect the heart and the lungs. And then we have bounding pulse, and then we have thready pulse, all right? So alternating strong and weak peripheral pulses are documented as pulsus alternans, all right? So it is a classic finding of severe left ventricular dysfunction. All right. Oh, let's see where we're at. Let's try to get the live up to 6,000. Oh, I'm gonna have no water. Oh, Lord. 6,000 if you don't mind. All right. By that time, I'll get my water. I left my water in the kitchen. Sorry. 2 seconds. All right. 2 seconds. Zorian? It's bedtime. It's bedtime. All right, sorry about that. All right. Okay. Oh, and I've gone all the way up to 6,600. Oh, thank you. All right. So, where would the nurse expect to hear early crackles in a patient with acute left-sided heart failure? Is it A, in the upper lobes, B, the bases of the lungs, C, the trachea, or D, the apex of the lungs? So where would the nurse expect to hear crackles in a patient with acute left-sided heart failure? A, upper lobes, B, bases of the lungs, C, trachea, and the D, apex of the lungs. Lord, we're tired. C, B, okay. All right, so why you say B, Asante? Because with the heart, like, you know, with the heart and the lungs, you know, you have the base of the, so for the lungs, so try to remember that with the base and the base and the apex of the heart and the lungs are basically the opposite. So the lungs, the apex is going to be at the top and the base is going to be at the bottom. It's the reverse for the heart. All right, so always remember that. So with where would the nurse hear early crackles in the patient with acute left-sided heart failure? It's going to be B, the base of the lungs. All right, so fluid accumulates in the dependent lung regions first, and then, which is the base, and then increases. Good night, good night, good night. Thank you for that. All right. Would it be, what would you hear in the trachea? What would we hear in the trachea? Let's see. What would you hear in the trachea? Just your regular What sounds are you listening for? Or is there anything? Just a regular inspiration, expiration. Yeah, just your tracheal breath sounds. There's nothing really. Okay. All right. Your striders. Okay. And the upper lobes. Okay. All right. So fluid accumulates in the dependent lung regions. All right. So definitely in the base of the lungs. All right. You'll hear. Which question is most important when initially assessing chest pain? So you have a patient that is, having chest pain. Which question is most important when you're assessing that patient? A, did you eat recently? B, what position relieves it? C, can you describe the quality, location, radiation of the pain? Or D, do you feel anxious? So you have a patient that comes in and the patient is having chest pain. How are you going to go about with, finding out a little bit more about the chest pain? Are you going to ask them, did you eat recently? What position relieves it? C, can you describe the quality, location, and radiation of the pain? Or D, do you feel anxious? So we have C, which is definitely C. You always want to go ahead and probe. Find out the characteristic, the location, what makes it better, what makes it worse, the onset, if it radiates, things like that. Did you eat recently? Who would you normally be asking that to? Oh, you want me to repeat? So which question is most important when initially assessing chest pain? Is it A, did you eat recently? B, what position relieves it? C, can you describe the quality, location, radiation of the pain? Or D, do you feel anxious? All right, and the answer is C. Can you describe the quality, location, radiation of the pain? All right. So you're always gonna go ahead and ask the characteristic, the location, onset, radiation, any other, associated factors that will help you distinguish whether or not it is cardiac versus non-cardiac. All right. So you always want to go ahead and find out all of that information. Did you eat recently? Sometimes you only ask, your patients who, if they have GERD or if you're thinking along that line, you can ask them, what did you eat? Because sometimes depending on the food that you eat, you tend to kind of have, some burning, epigastric discomfort. So you can always ask that question. But if you're thinking about, when it comes down to chest pain, you always want to find out if it is cardiac related. So you always want to find out, or you ask specific questions that is going to help you with determining if that patient is, at risk for any MI or anything like that. All right. So, an S4 heart sound is most likely heard in A, healthy adolescent, B, a patient with long-standing hypertension, C, a patient with acute pulmonary edema, or D, a patient with mitral valve prolapse. So S4 heart sound is most likely heard in A, a healthy adolescent, B, a patient with long-standing hypertension, C, a patient with acute pulmonary edema, or D, a patient with mitral valve prolapse. So Melissa says D. Okay. Do we have anybody else? D. Thank you for sharing the live, TS Music. Okay, it's a D. All right, so the answer is actually B, a patient with long-standing hypertension. All right, so S4 indicates decreased ventricular compliance, commonly due to hypertension or left ventricular hypertrophy. We had said that S3 is pretty common in younger adults, all right, and it's because of their age, the flexibility and the elasticity with their heart. So if it is, 35 to 40 thereabout, up to that age, it is pretty normal for them to have the S3. Anywhere after 40 years old, then that's a problem, all right? And then we say that S4 is anybody with like your long-standing hypertension. Acute pulmonary edema, I think that is gonna be with your S3 as well. All right. And that one is with your S3 heart zones. Heart zones. Conditions. So let's see some of the conditions here. Okay, so with your S3, you'll hear that with your mitral regurgitation, cardiomyopathy, or volume overload, that can cause severe anemia, thyrotoxicosis, or pregnancy, or in pregnancy. So your pulmonary edema is going to be for your S3. Your long-standing hypertension is going to be for your S4. Mitral valve prolapse is with your S3. Healthy adolescent is going to be, your S3 as well. So, and as I said, the cutoff age is going to be anywhere between 35 to 40. All right, so definitely look at that. Yes, remember to go ahead and like up the live. Thank you in advance. All right, and remember to share up the live as well. All right. Which action is correct when assessing carotid arteries? So palpate both simultaneously. Is it B, palpate one at a time gently? C, apply firm pressure? Or D, avoid auscultating the carotids? So which action is correct when assessing the carotid arteries? A, palpate both simultaneously. B, palpate one at a time regularly. C, apply firm pressure. Or D, auscultate, avoid auscultating the carotids. All right, so Melissa says B, Asante says A, and I think I see somebody else. Dorian says B. Okay, so who says A again? Palpate both. So Asante, why would you want to palpate both at the same time? See, I realize you don't follow everybody. Why you don't want to palpate both of them at the same time? Isn't that easier work for us? We're just going to do something like this. And why you want to do that? Why you want to palpate both at the same time? Just get it over with. Not sure. Both can prevent blood flow. Yes, so you don't want to do both of them at the same time because you don't want to, put that patient out. All right, just imagine you cut off, the blood flow to the brain. All right, you definitely will make that patient pass out. All right, so you don't want to do that. So you do one at a time. All right, so reduce oxygen and cause collapse, definitely. So you don't do both at the same time. All right, I know it sounds easy for us to do and be like, oh yeah, I'm in a rush, let me just palpate both of them and just cut. But you don't want it to be a case where you're there, you press for too long, and then you realize the patient just passed out. So the correct thing is to do one at a time, all right? And you also want to do it gently. You don't want to be like, massaging, because especially your elderly patients, if they have, atherosclerosis or anything, you don't want to break off any little, pieces of fat or anything that can cause like, that can cause blockage, all right, and give the patient probably a little mini stroke or anything like that. So be gentle when you're palpating. Don't go there and rub out the people in their neck, all right? Don't do it. So you apply firm pressure. No, you just gently, do your little thing. Palpate one at a time. Do not apply firm pressure. Avoid auscultating the carotids. No, you want to auscultate the carotids. All right, you want to listen to the sounds there. So definitely you can't avoid it, all right, or else you're not going to complete your exam. And then avoid palpating both simultaneously. Yes, Melissa. All right, so carotids must be palpated separately to prevent reduced blood flow. All right, cerebral blood flow. A client with cool mottled legs and absent pulses may have A, chronic venous insufficiency, B, acute arterial occlusion, C, right-sided heart failure, D, dehydration. So you have a patient that is cool, mottled legs, and absent pulses. What are you thinking about? So if you don't have any pulses, the leg is looking cool, or the extremity is just looking cool, it's mottled looking. What are you thinking about there for that patient? Is it A, chronic venous insufficiency, B, acute arterial occlusion, C, right-sided heart failure, or D, dehydration? So what's your answer? So the client is cool, mottled legs, and absent pulses. What are you thinking? A, chronic venous insufficiency. B, acute arterial occlusion. C, right-sided heart failure. D, dehydration. So a client with cool mottled legs and absent pulses may have A, chronic venous insufficiency. B, acute arterial occlusion. C, right-sided heart failure. Or D, dehydration. Asante says A, which is chronic venous insufficiency. Do we have anybody else? Okay, no problem, no problem. All right, so the answer is actually B. All right, so Angela says A. The answer is actually B. So just remember that the patient don't have any pulse. All right, so the patient don't have any pulse down there. It's going to be cool mottled, but you're thinking about some occlusion. You're not having blood flow going down that side. Chronic venous insufficiency. Some is passing through, but not enough. All right, so you might tend to have, with chronic venous insufficiency, you tend to have like, pain, swelling, the skin might change, and you probably tend to have like ulcers. With the acute arterial occlusion, when you have that vessel being occluded, it's going to be mottled, it might look blue, purple-like, it might just be cold, and the pulse is just so weak or it's absent. Right-sided heart failure, you tend to have your edema. You tend to have your not your pulmonary edema. You tend to have your peripheral edemas. You tend to have your abdomen being swollen, things like that. Dehydration, I don't think with dehydration you tend to have absent pulses or mottled, legs. Cool. No, with dehydration you tend to be a little bit dry. The pulse might be weak and thready, things like that. All right, but anytime you hear about the absent pulse, you're thinking about poor perfusion, a blockage. So sudden loss of pulses with mottling, such as arterial occlusion, which is a vascular emergency. So go ahead and call your doctor, let them know that you can't feel any pulse, you mark the area, and then from there, prep the patient for the OR. All right. Which diagnostic test measures intracardiac pressures directly? So when you hear intra, what is intra? So if somebody said that we're going to monitor the intracardiac pressure, you're thinking about the pressure inside of the heart. All right, definitely. So which diagnostic test measures intracardiac pressures directly? A, echocardiogram. B, right-sided heart catheterization. C, chest x-ray. Or D, electrocardiogram. So which diagnostic test measures intracardiac pressures directly? A, echocardiogram. B, right-sided heart catheterization. C, chest x-ray. Or D, electrocardiogram. So if the doctor says, okay, then we're going to do this kind of test on a patient, which one are you thinking about? Anyone on YT? Asante says B, right-sided heart catheterization. Do we have anybody else who will save their patient? So the options are A, echocardiogram. B, right-sided heart catheterization. C, chest x-ray. Or D, electrocardiogram. So if the doctor says that we're going to be doing a diagnostic test to measure the intracardiac pressures directly, which test are you anticipating? Is it the echocardiogram? Is it the right-sided heart catheterization? Is it the chest x-ray or electrocardiogram? All right, you have a patient here. So A, echocardiogram. So the answer is actually B, the right-sided heart catheterization. So remember, the intracardiac pressure. So you're going to check the pressure inside of the heart. All right. Echocardiogram, you're looking at the heart. So it's more like an ultrasound of the heart. All right. So they'll put on the gel And then they'll do, you know, just like when you have, you know, for persons who have been pregnant, and you've seen multiple, you know, TV series and everything with pregnant women doing their ultrasound. It's something similar to that, where you look at the heart itself. So you don't, it's not a procedure that you have to cut into the skin, you know, to get into to see. Right side of heart catheterization. I don't know if you've heard about the Swan-Ganz. A lot of times it's in the ICU they tend to do that. And that one is when they directly go in the heart and measure the pressure on the right side. Chest x-ray, you know, I hear the doctor saying that we're going to measure the intracardiac pressure when they talk about chest x-ray. Chest x-ray, does the regular chest x-ray. You look for your pneumonia, you look for anything that is broken in terms of your bone, you know, things like that. Your electrocardiogram is the same thing as your EKG. All right, so you'll just put on the stickers and, you know, you get the reading from the chest wall of the heart. All right. So the Swan-Ganz, or the right-sided catheterization, is the one that provides direct measurement of your intracardiac pressures. And as I say, a lot of times you'll see the patients in ICU. This is what, you know, some of them will be on. All right. A client reports calf pain with walking that stops at rest. So you have a patient that says, oh my God, the back of my calf is just paining me, but every time I rest, it feels so much better. By the time I start walking, it gets worse. All right, this is called what? Is it A, angina pectoris, B, intermittent claudication, C, deep vein thrombosis, or D, rest pain? So a client reports calf pain with walking that stops at rest. This is called A, angina pectoris, B, intermittent claudication, C, deep vein thrombosis, or D, rest pain. So I have B, C, C. Okay, the answer is actually B, the intermittent claudication. So sometimes just look at the question and look at the answers that you have, and you will, if you don't know the answer or the different, you know, the options that they give, they can always, like, you know, just mark off, rule out. So a client reports calf pain with walking that stops at rest. So it means that every time the patient is walking, you know, the patient is having the pain, but once the patient stops walking, then the pain goes. So there is something that is happening intermittently. So the answer you have is angina pectoris. With angina pectoris, we know that where are you having pain with angina? Is it in the head? Is it in the belly? Is it in the foot? Like, where are we having pain when it comes down to angina pectoris? The heart, all right? Deep vein thrombosis, where are you having the pain? And is it something that, you know, you tend to have when you're, yeah, well, then again, you will have it, but not sometimes, it's not something that you hear patients say that they tend to have rest. Whenever they rest, it gets better. All right, so you tend to have it in the leg, all right, your deep veins there. So a lot of times they tend to have it in the calf, all right, of their legs. Rest pain, I guess rest pain is rest pain. But intermittent claudication is the one that is most fitting, even if, you know, we probably don't know much about it. All right, because if you're trying to use the process of elimination, then that would have been the one that is most appropriate. All right. So if the client reports calf pain with walking that stops at rest, it is called intermittent claudication. Angina pectoris is related to the heart. Deep vein thrombosis is in the back of the leg, or, you know, a lot of times the patient will have pain when they're ambulating, but even when they rest, a lot of times the pain still is there. And then rest pain, I mean, I really know what that is, but rest pain is rest pain. All right. So claudication is exertional ischemic leg pain relieved by rest, and it's common in peripheral arterial disease. All right. All right. So before giving digoxin, the nurse teaches the patient to check their pulse and hold the medication if A, the pulse rate is what? So what is the range for, you know, what is the normal heart rate that you should no. So at what rate? Yes, so if you have a heart rate that is less than 60, would you go ahead and give your digoxin? And no, okay. So you hold it if the heart rate is less than 60. Okay, all right. And what's the normal, when it comes on to capillary refill, what are you looking for in terms of seconds? Like what is a good capillary refill time? 2 to 3 seconds, definitely, definitely. All right, so anything that is prolonged, greater than 3, usually is hypoperfusion, so that is something that is concerning. All right, and we says that with the digoxin, okay. All right, a client on digoxin reports nausea, blurred vision, and yellow halos around the lights. What should the nurse suspect? A, hypoglycemia, B, digoxin toxicity, C, myocardial infarction, D, stroke. So you have a client that is on digoxin and they report nausea, blurred vision, and halo around the light. Okay, BB, which is digoxin toxicity. So a lot of times you tend to have a GI upset, blurred vision, the yellow vision, or blurred yellow vision, and the arrhythmias. All right. Well, give me 3 signs or symptoms of hypoglycemia. What are some classic signs of hypoglycemia? Or just give 3. Jittering, okay. Two more, blurred vision. Sweating, okay. Changing the level of consciousness of the patient as well. For myocardial infarction, what are some, signs or symptoms for myocardial infarction? Are some of the classic signs and symptoms? You talk about your substernal chest pain, you talk about your left arm pain, jaw pain, things like that. Hypotension, sweating, yes, things like those. Stroke, what are some of the things you're looking for with a patient with stroke? The signs and symptoms. Talk about your facial drooping, weakness, slurred speech, yes. All right, weakness to the extremities or, unstable, okay. All right, so definitely. What is the antidote for your digoxin toxicity? Is it calcium gluconate digitalis? Okay. All right. So is it calcium gluconate, A, atropine, digoxin, immune fab, or you digibind, or you have sodium bicarbonate? So Dorian says the digitalis, digibind. Naloxone. What is naloxone for, Melissa? Digibind. Okay. Yes. Digibind. Yes. Yes. But I see you put naloxone there. What is the naloxone for? Oh, okay. But I still need the answer. Me no know. Opioid. Okay, nice. Yes, your opioid. Okay. When you have a patient that is on warfarin, what lab are you concerned about? What are you monitoring with a patient that is on warfarin? Is it the APPTT? You talk about the INR, platelets, or fibrinogen? So you have a patient that is on warfarin. Which lab tests are you concerned about to check for like the effectiveness? So your INR, PTT, definitely. All right, your INR. And what is your target, range for your INR that you're looking at? What are your target? What numbers are you looking at to say, okay, then this patient is, therapeutically at their range or their level? What number are you looking at for your INR to say that is your warfarin is effective. 2 to 3, definitely. All right. If you have a patient that is on your heparin infusion, which lab test will you be monitoring in the hospital? Are you going to be looking at your PT-INR, your PTT, your platelets only, or your hemoglobin? So you have a patient that is getting heparin infusion for their clots. What are you going to be checking to make sure that you're not thinning out this patient's blood? Your PTT, nice, definitely. All right, what is the antidote? So you're there giving this patient this heparin and you realize you give the patient too much. What are you going to be using as the antidote to counter the effects of that? What's the antidote for your heparin? Vitamin K. Okay, where something else. Your prothrombin. No, for your medication. What is going to be used to reverse your heparin? What drug are you going to be running for? So you give this patient the heparin and, you realize that the patient has gotten too much and you want to reverse it. What are you going to be running to the vitamin K or your protamine sulfate? I was looking for. All right. So you're running for your protamine sulfate for your heparin overdose. All right. If you have the warfarin overdose now, what are you going to be running for? Your vitamin K, yes. All right, so for your heparin, you always go for your protamine sulfate, and for your warfarin, you go for your heparin, your vitamin K. All right. A patient that is on nitroglycerin reports headache. What is your best response? Is that something that is pretty normal for a patient that is on nitroglycerin? What is going to be? Oh, yeah. Remember to like up the live guides. It's normal. Okay. Because what is happening? Why is the patient having this headache? Why is the patient having headache when it comes on to your nitroglycerin? It's normal for them to have it. Why are they having this headache, this sudden onset of headache? So it's normal for them to have it because of the vasodilate. Yes, the vasodilating effects of that. All right, so it is pretty normal for them to have it. So you can always encourage them to just go ahead and take some Tylenol to help with that. All right. So if you're supposed to give the patient a medication, how would you tell the patient to take it? Do you tell them to go ahead and inject it, put it in their, swallow it, put it under their tongue, put it in their eyes? Where would you tell the patient to put it? So you're sending the patient home with your sublingual. Nice. So you place it under the tongue and, you tell them it will dissolve. Definitely. And one thing that we always tell them that, if they're having, so for example, some patient will tell you that they have this burning effect or stinging effect under the tongue. Is that something that you would tell them that, oh no, you might not have that, or what would be your best response to them? So the patient says, nurse, that every time I take the medication, it always stings me. What would be one of your best response to that patient? Is it normal for them to have a stinging effect or burning effect from the nitroglycerin once they put it under the tongue? Yes, a lot of times they tend to have the burning effect or the stinging effect, and most of the time it's because that's one way for you to tell that the medication is actually working. So a lot of times when patient, yes, it goes away. If they don't have that feeling, sometimes the medication is like expired. So always tell them that they will find, this burning or stinging effect whenever they put it under the tongue and it starts absorbing. A lot of times if they're, taking the medication and they're not getting that, sometimes the medication bottle just expire. All right, so always double check that with the patient. All right. And how many tablets do you encourage your patients to take, or usually is prescribed? Nice, 3. So for example, you give the patients the 3 medications because the patient is having chest pain, and the patient is still having pain after you've given the 3 nitroglycerin. What else can you give the patient in terms of, or what can you advocate on behalf of the patient, or according to ACS, what other medication can you give apart from aspirin in terms of a pain for this patient? What are you thinking or anticipating that the doctor is going to order? All right, you remember your Mona? All right, remember your Mona? So your morphine. All right, so always remember that you can always go ahead and ask the doctor to go ahead and get you some morphine to see if that will help with the patient's pain as well. All right. So you have a patient that is on ACE inhibitor, which finding requires you stopping that medication immediately. All right. Give me 1 example or 2 examples of an ACE inhibitor. Lisinopril, nice. So if you have a patient that is complaining that, you know, they're having, yes, so lisinopril. So if you have a patient that is complaining that, oh, nurse, every time I take this medication, I'm just coughing. Would you tell the patient to stop taking that medication immediately? No, okay. Okay, stop taking the meds. That is a side effect. Okay. So what, so the patient is on the lisinopril and the patient is having the cough. At what stage, or if the patient starts developing, let me read the question. So which finding requires you stopping the ACE inhibitor immediately, which is the lisinopril, any other medication that has pril? Is it the dry cough, the dizziness, the angioedema, or the hypokalemia? The angioedema, yes. That's the only time you're going to tell them to stop taking the medication immediately. What are you concerned about with angioedema? Or is angioedema something we can say, okay, then we'll call the doctor tomorrow morning? Okay, definitely. The airway. You want to make sure that, you know, the airway is protected because it's a life-threatening condition. Definitely. So you'll tend to have your swelling of your lips, you know, your face and your tongue. So you definitely want to make sure you tell the patient, don't take any more of that medication. Show up to the emergency room or call 911, you know, that kind of thing. All right. Mona, welcome. All right. What are some of the electrolyte imbalance that might happen with a patient that is on ACE inhibitor? So your patient is on the lisinopril. What are some of the electrolytes that you're anticipating that is going to be out of, you know, the norm? You're going to have hyperkalemia. Okay. All right. So you tend to have your hyperkalemia. All right. You tend to have your hyperkalemia. Good night. You tend to have your hyperkalemia with your ACE inhibitors, all right, because they tend to have potassium retention going on, all right. Can you give me two medications that are beta blockers? 2 examples of a beta blocker. Metoprolol, okay. Labetalol, definitely. Amlodipine, what class of drug is that one? And the atenolol, nice. Amlodipine, what class of drug is that one? Propranolol. So anything that has a lol is your beta blocker. All right. Your amlodipine, what class of drug is that one? Your calcium channel blocker. Nice, nice. Lisinopril, what class of drug is that one? Your ACE inhibitor. And furosemide, what kind of drug is that one? Yes. And furosemide? Is your loop diuretics. Nice, nice. All right. So your beta blockers tend to end in your lol, your metoprolol, your atenolol, propranolol, definitely. What kind of drug is torsemide? It's a loop diuretic, definitely. Yes. Yes. All right. So you have a patient that is on your beta blockers, right? You have a patient that is on your beta blockers. So your atenolol, propranolol, all of those lol. What are some adverse effects or, side effects that are concerning for you? Is it dry mouth, bradycardia, mild dizziness, or fatigue? What is concerning for you? You have a patient that is on, your beta blockers. Which of the side effect is concerning for you? B, brady. Okay, yes, definitely a bradycardia. Because with the beta blockers, it actually slows down everything. So it slows your heart rate. So you tend to have you can have severe bradycardia, which is, life-threatening for the patient. And thank you everyone for showing up, all right? So you have a patient that is asthmatic, all right? You have a patient that is asthmatic. Are you going to be concerned about that patient being on, a beta blocker? So you have a patient that is asthmatic, and the patient is on a beta blocker. Are you concerned about that patient? Why are you concerned about that patient, Dorian? Yes, Asante says yes. Okay. Why are you concerned about the patient, though? This patient does have asthma. And we know that we're giving the beta blocker for the blood pressure. Why are you concerned about the patient asthma? Like asthma and the blood pressure have nothing to do with each other. It decreases the pulse, bronchoconstrictions, yes. So it causes bronchoconstriction and can cause, worsening of that asthma. So you have to be concerned about that. Are you concerned about the patients who are diabetic as well? The patient is a diabetic, the patient is on atenolol, or the patient is a heart failure patient, and the patient is on, propranolol. So for example, are you concerned? Yes, you're concerned. Why are you concerned, Gucci? So Asante Dorian says, yes, they're all concerned. Why are you concerned about that one? As I said, we're giving it for the heart. Why are you concerned about the patient who is diabetic being on it? Mask hypoglycemia, definitely. See, exacerbation can cause blockage in the airways. Okay. Okay, so for the patient that is diabetic and is on the atenolol, yes, it masks hypoglycemia. So you want to make sure you're checking that patient for, their glucose to make sure it's not causing a drop in their glucose level. All right. A nurse is teaching about calcium channel blockers, and we said that one example would have been your nifedipine, your amlodipine, anything that has the pine. All right. Which statement by the patient shows understanding? A, this medication will raise my blood pressure. B, I may feel ankle swelling while on this drug. C, I should avoid bananas with this drug. D, I can stop it if I feel dizzy. So you have a patient that is on calcium channel blocker and you're teaching this patient about the medication. Which statement by the patient shows understanding? This medication will raise my blood pressure. B, I may feel ankle swelling while on this drug. C, I should avoid bananas with this drug. Or D, I can stop if I feel dizzy. Carousel says B. Island Girl says B. Okay. All right, nice. And Mona says B. I may feel ankle swelling while on this drug. So if the patient says that to you, which statement by the patient shows understanding? I may feel ankle swelling while on this drug. So which medication is going to cause the patient's blood pressure to raise? What medication will cause the patient's blood pressure to raise? Give me one medication that we use to, the patient's blood pressure is very low. What is one medication we're going to give to increase the patient's? Midodrine, definitely. Okay. Anything else we can use to increase a patient's blood pressure? Epinephrine. Levo, all of those things. All right, yes. All right, so I should avoid bananas with this drug. Should they be avoiding banana? Dobutamine, levo, yes. I should avoid bananas with this drug. Should they be avoiding bananas with calcium channel blockers? So you have a patient that is on calcium channel blockers. So should they be avoiding bananas? Because bananas has a lot of potassium, right? Should they be avoiding bananas in with a patient that is on calcium channel blocker? All right, doesn't really matter. Yes, okay. All right, and I can stop if I feel dizzy. Should they stop the medication if they're feeling dizzy? Should they be feeling like, super dizzy with these medications? Well, a lot of the patients tend to have dizziness. At least some of them will have dizziness as a part of the side effect. They'll tell you. But should they stop the medication if they feel dizzy? No. Okay. All right. So if the patient takes the medication, the patient is feeling dizzy, lightheaded. What are you thinking about that is going on with this patient? So the patient takes the blood pressure medication. Patient is starting to feel dizzy, lightheaded. Their blood pressure. What about their blood pressure, Mona? Low. Okay. So yes, so you're thinking about hypertension. And what is one way you can actually help with, managing or making sure that the patient is not going to be passing out on the floor? So you're thinking about your orthostatic hypotension. All right, you're thinking about orthostatic hypotension. So one thing you can do is just have them lie down to help with the flow of the blood back to the heart, the brain, and all. All right, fluids and rest. All right. So the answer is the nurse is teaching about calcium channel blockers such as your amlodipine or your nifedipine. Which statement by the patient shows understanding? I may feel ankle swelling while on this drug. And the answer is B, because peripheral edema is a common side effect of calcium channel blockers. All right. A client receiving amlodipine should be monitored for A, is it hypertension, B, hypotension, C, hyperkalemia, D, tachycardia? So a client receiving amlodipine should be monitored for hypertension, hypotension, hyperkalemia, or tachycardia. So Gucci says hypertension. Do we have anybody else who's going to be monitoring something different? All right, so remember the patient is, why are we giving amlodipine? Gucci. So we're giving the patient for the hypertension, the high blood pressure. All right, so you're going to monitor the patient for hypotension because you're thinking about, vasodilation, a drop in the blood pressure happening when the patient has taken that amlodipine. All right, so you'll be checking for your hypotension and not hypertension. I don't know if that was a typo error. All right, what class of drug is statin? What class of drug is your statin? So you have a patient that is on a statin medication. What class of drug are you thinking, or why is that patient getting that medication? Cholesterol. Okay, good. Give me 2 cholesterol. Yes. Give me 1 medication that is considered a statin. 1 example of a statin medication. Remember to go ahead and like up the live. Thank you so much. Atorvastatin, simvastatin, all of those. All right. So which drug is classified as a statin? The simvastatin, which is the B, and it lowers your cholesterol level. All right. What rosuvastatin? Yes. All right. What lab would you be monitoring for a patient that is on a statin? So you have a patient that is on a statin, which lab would you be concerned about? Thank you, Trish, for liking up the live. All right. What labs would you be concerned about with a patient that is on statin? Okay, so cholesterol. Okay. Would you be concerned about the liver for this patient? So you want to be, yes, so you want to be monitoring your liver enzymes for your patient that is on your statin. All right. Always keep a close eye on that. All right. So say for example, you realize that the patient is having dark colored urine. Patient is having dark colored urine. The patient is on statin. The patient is also having probably like some muscle pain. Are you concerned about that? Or are you just thinking that, oh, probably the patient never drink enough water? Are you concerned about that or not? Yes, all right. So you're concerned about it, Dorian. Why are you concerned about that patient with a concentrated urine on statin and having muscle pain? What are you thinking? Rhabdo, okay. Liver damage, okay. All right. So I see Cupid's here says rhabdo. Okay, so what test would you be checking for your rhabdomyolysis, Cupids? So Island Girl says liver. So okay, so you'll be checking for liver function test for your rhabdo. Okay, you'd be more checking for like your myoglobin for your rhabdo. I was looking for your liver function test for your liver for your statin patient. So if the patient is having like the dark color urine and they're on the statins, I'm thinking more about the hepatotoxicity toxicity that comes with the statin, AST, ALT. Yes. All right. So definitely with your statins, you always want to be keeping a close eye on your liver function. All right. With the rhabdo, most of the time the breakdown or the dark color urine is because of the breakdown in the muscle. All right. So you're thinking about like your myoglobin. You'll be checking for that. All right. So I was thinking about along that line. All right. So So with the statin, so the nurse must monitor liver function in which client? The client's taking ACE inhibitors, B, the statins, or no, A is statins, B is ACE inhibitors, C, beta blockers, or D, loop diuretics. So if you have a patient that is, you're welcome, no problem, Cupids. All right, so if the nurse is monitoring a patient's liver function, you'll be concerned about the patient that is on the statin, which is A, B, which is the ACE inhibitors, C, which is the beta blocker, or D, which is the loop diuretic. And we have Gucci says A, which is the statins. All right, as we had said before. So statins may cause hepatotoxicity, and so you want to monitor your liver function test. All right. All right, a client on a statin therapy develops muscle pain. The priority nursing action is to what? A, reassure the client. This is expected. B, discontinue the statin and notify the provider. C, give acetaminophen for pain. Or D, encourage ambulation. So you have a patient that is on statin and the patient starts having muscle pain. The priority nursing action is to A, reassure the client. This is expected. B, discontinue the statin and notify the provider. C, give acetaminophen for pain. Or D, encourage ambulation. So Carousel says A. Oh, Carousel says B, discontinue the statin and notify the provider. Do we have anybody else who wants to try and save their patient? Just one more. Nobody else? Son prefer losing a license? I see 16 persons up there. Just one more person. You have a patient here. You have a patient here. Just choose one. Okay. All right. So definitely go ahead and discontinue the statin and notify the provider. All right, so you're thinking about with the fact that the patient is having the muscle pain. Oh, so okay, I think I see where Cupid's was going. Okay, all right, Cupid's was one. Are you still here, Cupid? Cupid was one step further than where I was in terms of thinking. All right, so with the muscle pain as well, you're thinking about the rhabdo. All right, so definitely the myoglobin you want to keep an eye on. All right. Yes, you're still here. Okay, yeah. So you're thinking about your rhabdo, your muscle breakdown. And so you want to make sure that you're monitoring that. All right, so if you go ahead and discontinue the statin and notify the provider regarding that muscle pain there. Would you be giving this patient Tylenol? Would you, like, so for example, you know, you have Tylenol on board, or you have the PRN Tylenol there and the patient is having the muscle pain, would you go ahead and give this patient the Tylenol? Would you go ahead and give this patient the Tylenol? No. Okay. Why you want to give the patient the Tylenol though, Carousel? You know, Tylenol is over the counter and it's right at the bedside, you know, right at the bedside. And the patient said, nurse, the pain is like, you know, I'm having a lot of pain. But you know that liver toxicity. So the patient liver already damaged. So you don't want to go ahead and give that Tylenol to that patient with an existing liver damage, all right? Because you're going to just further worsening that, all right? Which medication is a direct vasodilator used in hypertensive emergencies? All right, so bedtime. So which medication is a direct vasodilator used in hypertensive emergencies? A, hydralazine, B, atorvastatin, C, metoprolol, or D, digoxin. Which is a direct vasodilator used in hypertensive emergencies? A, Carousel says A, hydralazine. Do we have anybody else? Gucci says A, or Gucci says A, yes. Hydralazine is a direct arterial vasodilator used for severe hypertension. All right. A nurse should instruct a patient on clopidogrel. What is the other name for clopidogrel? What is the other name for clopidogrel? Plavix, nice. So a nurse should instruct a patient on clopidogrel Plavix to report A, dizziness, B, headache, C, black stools or bleeding gums, D, mild nausea. So a nurse should instruct a patient on clopidogrel Plavix to report A, dizziness, B, headache, C, black stool or bleeding gum, or D, mild nausea. Gucci says C, okay. Do we have anybody else? Carousel says C, which is the black stools or bleeding gum. All right. So for example, the patient, yes, that's right, Dorian. All right. So why are you concerned about that? Why you tell the patient specifically that, you know, they need to report that? Because what class of drug is Plavix? Or what is the patient at risk for? Antiplatelet, okay, bleeding, yes. So the patient is at risk for bleeding. So with this, the patient, you know, has like, you know, the patient is home, the patient is starting to have, you know, a little bit of a headache, and the patient has ibuprofen. The patient has Aleve at the bedside. Would you tell this patient to, you know, just take some Aleve whenever you're having the pain? Is it okay for you to go ahead and tell them to take the NSAIDs? No, okay. Why not? Because remember that, you know, ibuprofen and Aleve are so much cheaper than some other medication. Why you wouldn't tell the patient not to take the medication? So you're going to tell the patient that, oh, you're going to waste that ibuprofen, the risk for further bleeding from your NSAIDs. Nice. All right. So clopidogrel increases bleeding risk. Black stools indicate GI bleeding. All right. If you have the patient that is having, you know, dark color stool, where are you thinking about? Is it upper GI bleed or lower GI bleed? Upper, okay. Why? How would you tell? Why? How would you know it's upper? How would you differentiate? In terms of like, you know, or no, not how would you differentiate, but what is happening with the upper GI bleed that makes it black? What is happening with that? Why you're thinking it's upper when you have a patient that has black color stool? The blood is digested, yes, and it mixed up with, like, you know, all of that hydrochloric acid there. All right, so it comes out, you know, black. When it is upper, then it tends to be bright. When it's lower, then it tends to be bright red. All right. And which diuretic is potassium sparing? Is it furosemide, hydrochlorothiazide, spironolactone, or bumetanide? Which of them is potassium sparing? Furosemide, hydrochlorothiazide, spironolactone, or bumetanide? C. Okay. Spironolactone, definitely. All right. So you'll definitely want to monitor for what in this patient. What labs are you going to be monitoring for or anticipating that is going to be elevated? Your potassium, definitely. Hyperkalemia. All right, nice. All right. So you have a patient that is having acute angina. Which medication is most effective for the relief of angina pain? Is it the oral isorbide? Is it B, sublingual nitroglycerin, C, nitroglycerin patch, or D, the beta blocker? So which medication is, you know, most effective for rapid relief of that angina pain? The nitroglycerin, but is it the patch or is it the the sublingual? Which one works faster? You know, the patch, you just put it on the patient, you know. You have to go tell the patient, open your mouth, put it under the tongue. Which one works faster? The sublingual? Okay, nice, yeah. All right, so the lip sublingual works faster. So, for example, you're taking out this, you know, one thing that as a nurse we tend to do a lot of times, you know, some persons will do it without even knowing. Taking that medication, the patch itself, you know, or the medication itself, and not wearing a glove. Some persons might not be wearing a glove and they go ahead and touch the medication. What can happen to that nurse by holding on to the sublingual or the nitroglycerin tablet? What can happen with the patient, with the nurse, because of that encounter with the nitroglycerin? If they're not wearing a glove, what are you anticipating? Depending on how long they have it in their hand and things like that. So depending on their exposure, how long they have it in their hands, sometimes they can actually pass out because of that. Can actually drop their blood pressure. All right, so always remember to put on your glove whenever you're handling your nitroglycerin, because you don't want to be the patient of the day. All right, so always remember to be wearing your glove. All right, isorbide. What conditions do we normally use that with in terms of a patient? What conditions we normally treat with isorbide? That medication. Isosorbide. Hypertension, yeah. Okay, yeah. All right. A client with acute coronary syndrome is placed on oxygen. The nurse knows oxygen is primarily given to A, prevent infection, B, increase myocardial oxygen supply, C, reduce blood pressure, D, improve lung expansion. So if a client that has acute coronary syndrome and is placed on oxygen, why are you giving the patient oxygen? Is it to prevent infection, increase myocardial oxygen supply, reduce blood pressure, or improve the lung expansion? Myocardial oxygen supply, yes. You want to increase your myocardial oxygen supply, B, definitely. All right, if you don't increase your myocardial oxygen supply, what can happen as a result of that? If the patient is having chest pain and you're not giving, you know, enough blood, you're not giving enough oxygen, what can happen? Oh, myocardial infarction. Yeah, the ischemia, myocardial ischemia. That can happen because of the lack of, you know, blood flow to the heart. All right, oxygen to the heart, ischemia, cardiac death, definitely. All right, cardiac cell death, yeah. All right. The priority nursing action for a client with chest pain unrelieved by nitroglycerin is, I think we said that before. So the priority nursing action for a client with chest pain unrelieved by nitroglycerin is to do what? You tell me the answer, because we already say that earlier. Let's see. I know probably you're not here. All the persons are not here, but if you've given the patients the nitroglycerin, they're still having the chest pain, what would be the next action? What medication can you give? Is it administer morphine sulfate, B, encourage ambulation, C, provide high protein snacks, or D, apply warm compresses to the chest? Another dose. So for this patient, you've given the 3 doses of the nitroglycerin. So the patient is still having, you know, the chest pain, and you've given your 3 doses of nitroglycerin. What can you do? Administer morphine sulfate, B, encourage ambulation, C, provide high protein snacks, or D, apply warm compresses to the chest? A, administer morphine sulfate. Island girl, why are you giving morphine to the patient? Decrease cardiac load, yes. All right, so you decrease the oxygen, the myocardial oxygen demand there. All right, and it also relieves the pain. All right, so you're having this patient that is, the patient is having the pain. Would you encourage ambulation, or why you wouldn't want to tell the patient to go and walk? Tell the patient, oh, you're having the chest pain. All right, go and walk a mile. Would you tell the patient to go and walk a mile? Just go and walk down the road and just breathe in and out. That is going to worsen their chest pain. You understand? You're telling the patient to walk and go die, basically. Providing high protein snack for this patient, you probably want to keep them NPO, because especially if you do the EKG and you notice there are changes, if it's something that needs to go to the cath lab, then definitely you want to keep the patient NPO during those times. So for me, every time a patient comes to the emergency room, it's always a nothing by mouth. You understand? Because their situation can change at any time. So always, keep them NPO. Apply warm compresses to the chest. I don't really know if that'll go help, but if the patient wants it, I think you should be able to provide a little bit of a warm compress. But I wouldn't have done that, but that is not priority action for me. All right. So a client with a ST segment elevation. Other three are not really necessary. Definitely. Yeah. A client with a ST segment, elevation MI is being prepared for percutaneous coronary intervention. The nurse should expect A, NPO status and informed consent. B, administering oral anticoagulants only. C, strict bed rest for 48 hours before PCI. D, encouraging high fluid intake before the procedure. So you have a patient that has a STEMI that comes in and you're going to prepare this patient for PCI. What should you expect? A, keep the patient NPO and get an informed consent. B, administer oral anticoagulants only. C, strict bed rest for 48 hours before PCI. Or D, encourage high fluid intake before the procedure. A, definitely. So NPO status and get your informed consent. All right, administer oral anticoagulants only. No. All right, usually you want to go ahead and get your, they'll prep the patient. So most of the time you'll give your, you'll get your IVs going. They will start the patient on their heparin, things like that. You will also go ahead with your aspirin, all of those medications that they normally give for your ACS. Strict bed rest for 48 hours before PCI. It's an emergency. We don't know when we're going to have, like a EKG changes. So you can't tell the patients, go ahead and prep for something that, you don't know that is going to happen. Encourage high fluid intake before the procedure. No, as I say, it's an emergency when you're having a STEMI. So usually most of the time we eat already and come to the emergency room. So you want to keep the patient NPO at that time when they present. All right, so PCI requires a consent, NPO status, IV access, and anticoagulation therapy. All right, it's not only oral anticoagulation therapy. You're going to do your IV as well. All right. So after the catheterization via femoral artery, the nurse should prioritize what? A, keeping the leg straight and monitoring for bleeding. B, placing the client in high Foley's position. C, encourage ambulation for preventing clot. Or D, applying warm packs to the insertion site. So you have a patient that is, just did cardiac catheterization from the femoral artery. What should the nurse prioritize? A, keep the legs straight and monitor for bleeding. B, place the client in high Foley's position only. C, encourage ambulation to prevent clotting. Or D, apply warm packs to the insertion site. That's where we put sandbags and such as to prevent bleeding. Definitely. Okay. So A. So definitely you want to go ahead and, keep the legs straight and monitor for bleeding. All right, because remember, you're going through the femoral artery. So that's a very, very large artery there. So you want to make sure you're keeping a lot of pressure there to help with preventing bleeding after that catheterization. All right, so if you never normally look at patients, lower extremities, them belly, them groin, this is the one time you're going to lift up the sheet and look every second. Yeah, man. Go to the sides and be looking, peeping every now and again to make sure the patient is not bleeding out. All right. Placing the client in high Fowler's position. High Fowler's position is more like, you know, this kind of position here. It will eventually, you know, give you a little pressure on the side there, but you don't want to keep the patient in that position because the pressure on the side is also going to cause probably further bleeding as well. So having the patient in a supine position or straight line is a better position for them. Encouraging ambulation to prevent clotting. Well, usually you want the patients to ambulate, but not after having catheterization and having the femoral artery being, you know, used, because ambulating is going to cause pressure and cause further bleeding. So you don't want that. All right. So that's a no-no. Applying warm packs to the insertion site also is a no-no for me, because that is going to cause further dilation. You understand? The heat is going to cause further dilation and cause the patient to bleed out a little bit more. So you want to apply that pressure to help, you know, with clotting at the site and then to prevent this bleeding. All right. So the leg must remain straight to prevent bleeding, hematoma at the insertion site. All right. Which finding after cardiac catheterization requires immediate intervention? A, mild bleeding at the insertion site. B, a heart rate of 90 beats per minute. C, absent pedal pulse in the affected leg. D, small dressing with scant blood. So which finding after cardiac catheterization requires immediate intervention? Is it A, mild bruising at the insertion site? B, heart rate of 90 beats per minute? C, absent pedal pulse in the affected leg? Or D, small dressing with scant blood? So C, pedal pulse absent. Definitely. Anytime you see any pulse that is absent, yeah, run to that one. All right. So is it normal for you to have the mild bruising at the insertion site? Is that something that you're concerned about? So the patient might have mild bruising at the insertion site. Nothing for us to be like concerned about. Heart rate of 90 is normal. The small dressing might have on scant blood, or it might have on moderate amount of blood. It's pretty normal, you know. Just make sure you're monitoring and applying the pressure there. Absent pedal pulse is something that you definitely want to be looking at, because of the fact that, you know, you're thinking about what? If you don't have any pulse there after arterial occlusion, what are you thinking about? So somebody just going the arterial, you know, your femoral artery, you're thinking about a blood clot. So definitely that is an emergency that needs, you know, attention. So go ahead and call a provider and get the patient prep again, you know, for possibly going back to the OR. All right. So things like that. So absent pulses might indicate possible arterial occlusion, and that is an emergency. So always go ahead and make sure you are always go ahead and make sure you're checking your pulses for your patients. All right. A client recovering from an MI should be taught. Give me 1 second. All right, sorry about that. All right. So a client recovering from an MI should be taught to A, resume normal activity within 24 hours. B, follow a low-fat, low-sodium diet. C, avoid all physical activity permanently. Or D, stop taking prescribed beta blockers when symptoms improve. So you have a patient that just had, you know, a myocardial infarction, a heart attack. What are you going to tell this patient? Resume normal activity within 24 hours. B, follow a low-fat, low-sodium diet. C, avoid physical activity permanently. D, stop taking beta blockers when symptoms improve. B, okay, B, follow a low fat, low sodium diet. Why are you going to tell the patient that? Resume after is a no-no. Okay, so why are you concerned about the patient's, intake? Why are you concerned about the patient's diet that you want to talk to them about it? I think the patient already know. Why are you concerned about that? High salt, okay, BP. All right. So what we know about myocardial infarction and atherosclerosis and all. So your diet is one thing you have to stress. All right. So always go ahead and talk to them about, yes, high fat increases atherosclerosis. So you always want to go ahead and talk to them regarding diet because you don't want them to come back in the hospital with the same problem again. All right. So always go ahead and talk to them about their salt intake, their fat intake to prevent further, occlusion, the atherosclerosis, the buildup of the plaque in the arteries, all right, that is going to contribute to them having the heart attack. All right, you're going to talk about exercise and all of those, but the diet, the dietary intake is one thing that you are going to be stressing a lot on. All right, avoid physical activity permanently. No, dear. After MI, you're going to have to try to, not immediately, but, you're going to have to try to encourage them to get that as a part of their everyday, lifestyle. Get some exercise in. If it's going to be walking, slight jogging, whatever it is, encourage them to do some form of exercise. Stop taking prescribed beta blockers when symptoms improve. No, dear. You're going to be on this thing for, a long time, lifetime. So not when your symptoms improve. All right, when your symptoms improve, we know that the medication is doing what it's supposed to be doing, so you need to be maintained on that. All right, resume normal activity within 24 hours. No, not within 24 hours. You give them time to, the body to recuperate and everything. So, but diet modification helps with preventing atherosclerosis, and that is something that you want to encourage, the low fat, the low sodium intake with these patients. All right. A nurse is caring for a client with heart failure. Which finding indicates fluid overload? A, dry mucous membrane. B, decreased jugular venous vein distension. C, weight gain of 3 pounds in 24 hours. Or D, low urine output at night. So you have a patient that is having heart failure or is diagnosed with heart failure. Which finding indicates fluid overload? Is it A, dry mucous membrane, B, decreased jugular vein distension, C, weight gain 3 pounds in 24 hours, or D, low urine output at night? C, weight gain of 3 pounds in 24 hours, definitely. So I know I've never really worked on like med-surg where we weigh in patients, but those patients you want to be doing your daily weights on them, all right? Your strict intake and output to make sure that we're not accumulating on those fluid. Decreased jugular vein distension, is that something that is good or bad? If you have a decreased jugular venous, it's good, nice. Low urine output at night, depending on, so for example, what's a normal urine output per hour you're expecting for patients in general? What's normal, urine output? How much per hour you're thinking about? How much mils per hour are you thinking about? 30, 35 mils per hour. Yes, 30 mils per hour. All right, so you want to keep an eye on their urine output as well, definitely. All right, dry mucous membranes. What conditions are you concerned about with dry mucous membrane? When you see dry mucous membrane, what are you thinking about? Is the patient having too much fluid or too little fluid? Yes, dehydration. All right, nice. All right, and if you have increased jugular vein distension, are you thinking about too much fluid or too little fluid? Too much fluid, definitely. So you always want to make sure you're keeping an eye on that. All right, you're thinking about your fluid overload. Yes. All right, a client with pulmonary edema is in acute distress. What's the nurse's priority? Is it A, place the client flat in bed, B, administer oxygen and diuretics, C, encourage oral fluid intake, D, perform chest physiotherapy? A, B, C. Okay. So a client with pulmonary edema is in acute distress. What is the nurse's priority? A, place the client in a flat bed. B, administer oxygen and diuretics. C, encourage oral fluid intake. Or D, perform chest physiotherapy. Oxygen, okay, nice. All right, so always start off with your airway, breathing, and circulation. All right, whenever you're answering your questions for NCLEX, and always start off with assessment, using your assessment, as well when it comes on to your patient. So definitely the answer is your B, administer oxygen and diuretics. All right, so if the patient is in acute distress, it means that the patient just has too much fluid on board. The oxygen level is low because of that excess fluid in the lungs. It's not allowing for the patient to, the lungs to be expanding properly. So you want to go ahead and administer your oxygen, and you want to go ahead and pull that fluid. So you're going to do your diuretics as well. All right, to reduce that. Performing chest physiotherapy, is that going to be beneficial for this patient at this time? You have a patient now with chest, you have a patient with pulmonary edema, and the patient is distressed, and you're going to be going over there and say, yeah, let me just beat up your chest for a little bit. Yeah, no, that not going to work right about now. It's going to be good for your pneumonia patients, all right? It's going to be good for your pneumonia patients because it's going to help with kind of helping breaking up that, that infiltrates there. It helps with, getting a patient loosen up a little bit, all right? So that's not going to really help with that patient. Are you going to encourage oral fluids for this patient? What if the patient say, nurse, I can't breathe, but more want a turkey sandwich. We need some ginger ale. Are you going to give that patient that ginger ale and the turkey sandwich at that time? No, dear. You understand? A lot of times them get upset though, them can't breathe. But they're going to get upset at you. But you just have to know, no, you can't give them anything to eat or drink at that time. Sort out them lungs and them breathing first. And then after, once you're stable, you can eat. Right? That me say too. All right, placing the client flat in bed. What is the best position for this patient? Is it flat in bed, high folders, semi-folders, tripod position? What position would you put this patient in? The patient is having, difficulty. Put the patient in high folders to allow for better expansion. All right, just imagine lying flat. We can lie down flat. Well, some of us can, we can, but it's difficult for you to breathe that way. And not to mention if you're distressed, you're lying down flat and you're having a hard time and feeling as though you're drowning with all of that fluid that is in your lungs. That's going to be a problem. So put the patient in high folders position so that way the patient can breathe a little bit better, and from there. All right. So the correct answer is administer your oxygen and your diuretics. All right. Which clinical manifestation is most characteristic of right-sided heart failure? Is it A, dyspnea, B, crackles in the lungs, C, peripheral edema and ascites, D, pink frothy sputum? So which manifestation is most characteristic of right-sided heart failure? Is it A, dyspnea, B, crackles in the lungs, D, peripheral edema and ascites, or D, pink frothy sputum? C, okay, C, peripheral edema, ascites, okay then. And what do we know? How do you differentiate between your right-sided and your left-sided heart failure? So Erin, I noticed you said peripheral edema and ascites. Why you said that? What is, okay, so left lung, okay. All right, so if the patient has your right-sided heart failure, what side of the body is affected? So left lung, okay. Right peripheral edema, okay. And then if the patient has, okay. And then if the patient has left-sided heart failure, you're thinking about your, what are you thinking about? What are some of the signs and symptoms that you're thinking about for this patient? Pulmonary edema. So you're thinking about your crackles, all of those things. Your crackles, dyspnea. All right. Pink frothy sputum. Which condition is that? Okay. Your frothy sputum. So for your, okay. All right. So for your, okay. So, yeah, pink frothy. All right. Pink frothy sputum. Okay. So the right-sided heart failure leads to systemic venous congestion. So you tend to have your jugular venous distension, ascites, and your edema. All right. The nurse is caring for a client with DVT or deep vein thrombosis. The patient should avoid A, elevating the affected leg. B, apply compression stocking as prescribed. C, massage the affected leg. Or D, monitor for swelling and pain. So you have a patient that has a clot, a DVT. What should the nurse avoid? Is it A, elevate the affected leg. B, apply compression stocking as prescribed. C, massage the affected leg. Or D, monitor for swelling and pain. C, nice. Massaging the affected leg. Why you don't want to massage his leg? The patient is complaining of pain. Why you don't want to massage? Okay, nice, because you don't want to dislodge the clot. All right. All right. So if you dislodge the clot and it goes into the heart, what is it called? So you have this clot and you dislodge it. All right. You go and massage this patient because the patient is saying, nurse, I am just not feeling so well. I just need I just want you to rub down my leg. You just go there and start massage and, yes. So if it goes into the heart, it's known as a MI. If it goes into the lungs, it's a PE. And if it is in the brain, it is a... I never see anybody put that one yet. So if it goes in the brain, what is that one called? Embolus. Yeah, man, the same embolus. So if it goes in the brain, it's the same stroke, all right? So if the same clot moves and go all the way up in the brain, it will talk about the stroke. All right. So you wouldn't want to go ahead and massage the affected leg, all right? Because the massaging can actually dislodge it, and depending on where it goes, it causes different problems. All right. So monitor for pain and swelling. Is that something that is, that's going to be a part of your plan of care and is expected? Applying compression stocking as prescribed. Is that something that you would go ahead and, encourage a patient to put on? Classic signs and symptoms. Yes. Okay. So so you have a compression stocking, would you go ahead and yes, you definitely go ahead and put on a compression stocking to help with that clot there. And elevating the affected leg as well, you could do. All right. Thank you so much, Matu Claremont. All right. Which symptoms suggest pulmonary embolism? So what are some of the symptoms of PE, pulmonary embolism? So if you have a patient that comes in and you're thinking about PE, what are some of the things you're expecting this patient to be telling you in terms of their signs and symptoms? Dyspnea, anything else? Difficulty breathing, shortness of breath, tachycardia, good. Okay, would you expect this patient oxygen saturation to be normal or abnormal? Increased blood pressure. Well, you tend to have that as well. You can have the increased blood pressure. Okay, so their oxygen saturation is going to be abnormal. It's going to be low. Nice. So which symptoms suggest pulmonary embolism? A, gradual onset of pedal edema. B, sudden shortness of breath and chest pain. C, bradycardia. D, productive cough with yellow sputum. So the patient comes into you and, which of them is suggesting that the patient has a pulmonary embolism? A, gradual onset of pedal edema. B, sudden shortness of breath, chest pain. C, bradycardia. Or D, productive cough with yellow sputum. Sudden shortness of breath and the chest pain. Nice, nice. All right. But what if the patient is having the sudden chest pain and the shortness of breath, but then the patient say, oh, nurse, my left shoulder is paining me and, my neck is not feeling so well. My jaw is just not just not well. What would you be thinking as well? Would you be like, oh, I don't know. You're thinking along the line of MI as well. All right. So always go ahead and probe. Find out additional information so you can actually get towards whatever it is that you're looking for in terms of your diagnosis. So when they come in front of you, Don't be just thinking about pulmonary embolism. Have a differential diagnosis in the back of your mind and be thinking about what are the different things. So depending on what they're saying, how they're looking, you can always go with your question in whatever direction. Is this something that is respiratory? Is this something that is cardiac? And then from there. All right. So if they come to you and they say they have the shortness of breath and chest pain, always go ahead and find out, okay, then, are they having nausea? Are they having, any coughing? Are their SATs, low? Things like that. Just find out additional information to help with getting to the direction of where you are with your diagnosis. All right. So the PE is going to be acute dyspnea, chest pain, tachycardia, and anxiety. What if the patient is having productive cough with yellow sputum? What are you thinking? Bacterial, definitely, yes. What if the patient is a smoker? Would you be concerned about, what if they were just having the cough? Yes, so you'll be thinking about pneumonia. So what if they are a smoker? COPD, definitely. All right. So as I said, depending on, you have to take into consideration different things. Emphysema. So definitely go ahead and just probe. Whatever they're providing you with, you use that and, use up a differential diagnosis and from there. All right. Thank you for liking up the live and for the heart me. All right. And thank you everyone for joining in. We do NCLEX questions on Thursdays and on Tuesdays. All right. So definitely join us here. All right. Oh, and I go by the name of Stacy. That's my name. All right, so gradual onset of pedal edema. What are you thinking about there? So you have a patient that is having, is at home and the patient noticed that every day, the legs are just getting a little bit tighter or, a little swelling. Yes, you're thinking about your CHFO. All right, bradycardia, cardiac wise, but this one is the PE. All right. Which intervention is most important for a client with venous insufficiency? Is it A, avoid elevating the legs, B, apply compression stocking, C, restrict fluid intake, or D, perform vigorous leg massage? So which intervention is most important for a client with venous insufficiency? Is it A, avoid elevating the legs, B, apply compression stockings, C, restricting fluid intake, or D, perform vigorous leg massage? Blood flow, so compression stocking, definitely, because as the name says, always just sit down and just think about the words. Even if you don't know how to, if you don't know much about the diagnosis, sometimes the condition itself, they give you the answer by itself. If you're able to just kind of separate it, because venous insufficiency, insufficient. So some blood going there, but not much. All right. Just think of it like that. So which intervention is most important for the client with venous insufficiency? The answer is going to be the compression stocking because you want to help with that blood flow. All right. So compression stockings improve venous return and reduce the edema. All right. Avoid elevating legs. As I say, you don't want to avoid elevating the legs completely. You can elevate it, but you don't want to avoid elevating the legs completely. Restricting fluid, you don't want to restrict your fluids because you still want, you don't want to restrict the fluids entirely, all right? So you're still going to have the limits on your fluids, but you don't want it to be a case where you're restricting your fluids for your patient. The vigorous leg massage, you have to just be careful with that, all right? The word vigorous, just be careful with that. Because in the event that there is a clot or anything, you don't want to dislodge it. All right. So the one that is most important for the client is going to be the compression stocking. All right. A client with aortic aneurysm reports sudden severe back pain. What should the nurse do first? So you have a patient that has aortic aneurysm reporting sudden severe back pain. What will you be doing? Hi, Lotus. Thank you for tuning in. All right, so a client with aortic aneurysm reports sudden severe back pain. What should the nurse do first? A, administer analgesics. B, place the client in a supine position. C, call the provider immediately. D, encourage ambulation. What are you going to be doing for that patient? So you have this patient and you know that the patient has an aortic aneurysm. What are you going to be doing if the patient is having severe back pain? So I have here CCC, call the patient, Dave, for them. Okay, definitely call the provider. Why everybody want to call the provider this time around? Why you want to call the provider? What are you concerned about? So call for them, call for them. Yes, emergency, bleeding. Okay, rupture, yes. So the patient might just have a rupture there because of the back pain, the severe back pain. All right, so you want to call the provider so they can actually bursting off the vessel, definitely. So you're going to go ahead and call the provider so they can come now and prep this patient. In the meantime, you're calling the provider. What are you going to be doing for this patient? What can you be doing, as a nurse, taking care of this patient? What are some things you definitely want to be doing for this patient if they haven't done it already? Or where are you anticipating this patient going? Morgue, home, operating room, staying with you on the floor, ICU, depending on where the patient is. Where are you anticipating this patient going? Oxygen, large bore IV for transfusion, prep, surgery. Nice. All of those. Good, good. All right. What do you think about doing any blood pressure on this patient? Like, what do you think about doing blood pressures on this patient? Yes, vital signs, shock, signs and symptoms. Yeah. Would you be doing blood pressure or in terms of blood pressure, IV resuscitation? Yes. So for example, you do the blood pressure on the left arm. You do the blood pressure on the left arm. You do it on the right arm, and you notice that there is a significant, difference in the blood pressure. Is that something that you'll be concerned about, or what is recommended when you have a patient with aortic aneurysm in terms of blood pressure check? How you normally do it? They always encourage you to do it on all four limbs. All right. The feet up. Okay. Highly concerned if there is an imbalance. Definitely. All right. So always go ahead and get your blood pressure on all four limbs and then from there. All right. All right. So the answer is sudden severe pain may indicate rupture. So you want to, emergency intervention is going to be needed at that time. Administer analgesics. If they have the analgesics, I guess you'll give their pain medication, but the priority is gonna be the, calling the provider. All right, calling the provider. Would you have this patient be getting up out of bed, walking to the bathroom, things like that? Would you have this patient be doing any of that? So you have this patient that has the aneurysm. Would you get this patient? No, because you don't want to put any extra pressure on that, that aneurysm there. All right, so strict bed rest. All right, no movement at all. Tell them to breathe slowly. All right, you don't want them to do too much. All right, so always go ahead and keep this patient on strict bed rest. All right, so if you mean that you're gonna have to put in your catheter at this time, definitely go ahead and do all of those, because you don't want it to be a case where you get this patient up. Oh, let's go on the bedpan. You move the patient over onto the bedpan because, oh, it's a 30-odd-year-old and the 30-odd-year-old have energy. All right, no. Talk to the patient, let them know what's happening, put in a catheter for strict intake and output, and, minimize the amount of movement that the patient is going to be getting, because you don't want it to be a case where you tell the patient move and then rip the patient, aneurysm a little bit more. All right, so definitely don't do that. All right. Encourage ambulation. That's a definite no. Place the client supine position. No. Administer analgesic. Then from there. All right. A client with atrial fibrillation is at risk for what? When you have a patient that is having atrial fibrillation. You're good, Morrison. You have a patient that has atrial fibrillation. What is one thing that the patient is at risk for when you have atrial fibrillation? So if a patient that has atrial fibrillation, we always tend to be giving them, warfarin, So they're at risk for heart attack, yes. So they're at risk for, the clots. So blood clot, definitely. So the client is at high risk for a pulmonary embolism, stroke, myocardial infarction only, or renal failure. So a client with atrial fibrillation is at higher risk for A, pulmonary embolism, B, stroke, C, myocardial infarction only, D, renal failure. Which of the answer you're thinking? B, stroke. Lotus, you said stroke. Why you said B? And the user 141 says D. All right, so Lotus says B because of a clot. Okay, but pulmonary embolism is caused by a clot as well, myocardial infarction, clot as well. But why you are so concerned about the stroke? Repeat the options. Oh, so the options are A, pulmonary embolism, B, stroke, C, myocardial infarction, D, renal failure. So all of them are actually caused by, are caused by a clot. All right. So all of them are caused by a clot. But why the patient with atrial fibrillation is at higher risk for which of them? Which of them that patient is at higher risk for? Lack of blood flow. Okay. So all of them are caused by, except the renal failure there, is caused by, if you look at it, pulmonary embolism is caused by a clot. B is also caused by a clot, which is a stroke. And C, the myocardial infarction, is also caused by a clot. But with atrial fibrillation, a lot of patients are at higher risk for stroke because they're saying here embolic strokes are the most common. All right. So that's the rationale behind the stroke story. All right. So atrial fibrillation causes stasis in the atria. And because of that, you have embolic strokes happening. So the patients are at higher risk for that. All right. Renal failure. I don't think they're at higher risk for renal failure if they're having atrial fibrillation. All right. But as I say, all three of them, if you realize all three of them are caused by a clot. And so the highest one they're saying is the stroke. All right. So which medication is commonly prescribed to prevent stroke in atrial fibrillation? So what medication are you anticipating? Say you have a patient that has atrial fibrillation. What are you anticipating in terms of a medication for preventing stroke? Anticoagulants, definitely. So is it going to be A, furosemide, B, warfarin, C, nitroglycerin, or D, digoxin? So which medication is commonly prescribed to prevent stroke in atrial fibrillation? A, furosemide, B, warfarin, C, nitroglycerin, or D, digoxin? Carousel says B. Okay, Island Girl says B. Definitely your warfarin. All right, and what lab will you be monitoring for your patient that is on warfarin? INR, PTT, INR, definitely INR. All right. And what if you already overdose the patient on the warfarin? What are you going to be using to counter the effect of that? Your vitamin K. Okay, nice, nice. All right. Yes. Charlene Johnson says Narcan. What kind of drug is Narcan, Charlene? Okay. Yeah, but I still need you to answer though, if you don't mind. Okay, for overdose. Okay. All right. So you use it for overdose, but what kind of overdose for the Narcan? Okay. Yes, so for your opioid, all right, so your opioid. All right, so the medication that is commonly prescribed to prevent stroke and atrial fibrillation is your warfarin, all right? Anticoagulants like warfarin prevent clot formation, all right? A client with a pacemaker reports dizziness and a heart rate of 40 beats per minute. What is the priority for this patient, all right? So if you have a patient that is that has a pacemaker and they're reporting dizziness and heart rate that is bradycardic at 40, what is going to be your priority action for this patient? So you're with the patient, what are you going to be doing for this patient, or what are you thinking is happening with this patient? What are some things you can do for the patient? So the patient has a pacemaker. You realize the patient's heart rate is 40. The patient is dizzy, and the patient, blood pressure. You look on the monitor, you realize the blood pressure is a little bit soft. Let's say it's 90 over 50 or 85 over 50. You've been getting fluctuating blood pressure. Okay, you give atropine, but you go to the Pyxis right about now. You realize there's no atropine, but the patient is still dizzy. The patient is still, just sweaty. The heart rate is 40, 43, and then you realize the heart rate is like 35. You're still waiting on pharmacy to verify and send you to you with that medication. What can you be doing at this time for the patient while we're there waiting? All right, remember your little ABCs. You can always go ahead and give a little oxygen. Remember, it's at the top, Go ahead, yeah. Go ahead and put on a little oxygen on the patient, just to kind of help with, the oxygen level, the dizziness, things like that, because the patient is not perfusing well. So the patient is going to have the dizziness. Eventually, you're going to give your atropine. All right, but when you have that happening, you're thinking about malfunction with the pacemaker. Sometimes probably the battery is running low, things like that. There are different things you can be thinking. So Lotus says, check to see if the pacemaker is working properly through an ultrasound. Okay. But in the meantime, there are things you can do before you reach, that far. Yeah, so you definitely want to go ahead and check your pacemaker. So if you're working on the cardiac floor or in the emergency room, always know where your device for checking the patient's pacemaker is located in the hospital. All right. So the client with a pacemaker reports dizziness and heart rate of 40 beats per minute. What is the priority for this patient? A, document findings as expected. B, apply oxygen and notify the provider. C, restrict activity for the day or reassure the client. So which of the answer you would think you'd go ahead? B. Yes, so Dorian, B. Apply oxygen and, notify the provider. Heart rate of 40 with a pacemaker such as malfunction, it requires immediate intervention. Yes, Lotus. All right. Definitely. All right. So, atropine. Who had said atropine earlier? So Carousel says give atropine. What are you expecting to when you get the atropine? What are you gonna be expecting in terms of the blood pressure, heart rate, the temperature? What are we addressing in terms of with the atropine? We're looking at the respiratory rate. We're giving it for the heart rate. So are we expecting the heart rate to be increased? Yes, so increasing the heart rate with that. All right. Which sign indicates bronchial? Tanisha, welcome. Kind of lost there, so sorry. Yeah. All right. Which sign indicates pacemaker malfunction? Is it A, regular heart rate of 70 beats per minute, B, dizziness, syncope, or irregular pulse, C, normal sinus rhythm on ECG, or D, incision site healing well? Which sign indicates pacemaker malfunction? A, regular heart rate of 70, B, dizziness, syncope, irregular pulse. C, normal sinus rhythm on ECG. Or D, incision site healing well. B. Definitely dizziness, syncope, and irregular pulse. What's normal heart rate? Range. What's the range for normal heart rate for an adult? 60 to 100. What's for pediatrics or children? What are we looking at for heart rate in children? 100 to 120. And like neonates, your newborns, what are we expecting in terms of the range? Luminous, welcome. 120 to 160, definitely. All right, so if you see the mother come and they say, oh, the heart rate is 150, don't be running up and down like, with the babies, for the neonates. Don't be like running all over the department to find a doctor. All right, so remember to know the different range for your heart rate. So for example, with this patient, would you be expecting to have normal sinus rhythm on the EKG for a heart rate of 40? Yes, Lotus. So you have a patient with a heart rate of 40. Are you expecting to see normal sinus rhythm? What are we expecting on EKG? What rhythm are we looking to find? Sinus brady. Okay. And what medication we use to treat bradycardia? And I don't want, let me tell you who I don't want to answer. Yeah, I don't want you to answer. I want somebody else to answer. I know you said it earlier. Carousel. I don't want you to answer. What do we use for? Okay, Dorian answer. Nice. Atropine. All right. Atropine. Incision site healing well. That is pretty normal. All right. All right. So a patient has hypertensive crisis. The blood pressure is 220 over 120. Which action is priority for this patient? A, place the client in a supine position. B, administer IV antihypertensive. C, encourage oral fluids. Or D, apply warm compresses. So you have a patient with hypertensive crisis. The blood pressure is 220 over 120. Which action is priority? A, place the client in a supine position. B, administer IV antihypertensive. C, encourage oral fluids. Or D, apply warm compresses. A, I don't know if that one is for this one. So Carousel says B, C. Charlene says C. So B. Charlene. Okay, so I see a few persons. So Charlene says encourage oral fluids. Why are we giving this patient fluids now, Charlene? Or probably that's an error. Maybe dehydration. All right, so the client is hypertensive. The patient is in hypertensive crisis and has blood pressure of 220 over 120. Which action is priority? So the options are A, place the client in a supine position. B, administer IV antihypertensive. C, encourage oral fluids. Or D, apply warm compresses. Do you still want to go with your oral fluids? IV administration, actually, okay. All right, so the blood pressure is very, very high. All right, so this patient is hypertensive crisis. So definitely want to go ahead and administer your IV antihypertensive. All right, so all the persons who said B is correct. What is one medication you're anticipating for, for your antihypertensive patients? Well, name one medication that you would be anticipating giving this patient to drop this blood pressure. That is a vasodilator. Hydralazine, definitely. So your hydralazine is a vasodilator, pretty good with, you know, hypertensive crisis. So you'll be anticipating that one. All right. So definitely. So you want to go ahead. Why you want to drop the blood pressure real fast with, you know, with these patients? What are you thinking about in terms of with the organs? What is happening when you're having the blood pressure being so high? Well, you want to go ahead. Kidney damage, yes. Okay, so in terms of perfusion impairment, definite damaged blood vessels. So yes, you want to make sure that your, you know, the organs are not getting damaged. So you want to prevent organ damage because of lack of oxygen. Yes. All right. So you want to go ahead and drop the blood pressure, you know, real nicely to prevent, you know, end organ damage there. All right. Encouraging oral fluids for this patient, I wouldn't really go ahead and, you know, do any oral fluids for this patient, even though it might just sound like blood pressure. But, you know, it can be a case where the blood pressure gets so high and then the patient starts having stroke-like symptoms, things like those. So you want to go ahead and keep this patient NPO. All right, placing the client in a supine position. You know, I want to put this patient in a supine position, probably in a 30, 45 degree, you know, angle there. But like, no, you know, so that will be it. Warm, apply warm compresses. You know, really see the importance of that one. So the one that is going to be important is the IV antihypertensive medication. What are some other things that you could be doing for this patient? The blood pressure is this high. What are some other things you'll be doing for this patient as the nurse? All right. You're waiting on that order for the, you know, waiting on that order for the hydralazine. You're waiting for pharmacy to dispense it. What are some other things you can be doing for this patient? So you have the patient, and the patient has a, let's say the patient has a little IV down here, right down here, you know. We have a little IV down here. Would you go ahead and get a second IV on this patient or a third IV on this patient? Would you get EKG on this patient? Connect this patient to the monitor, things like that. Yes, definitely. Go ahead and get, you know, your large bore IVs, get your EKG, get your patient connected to the monitor, you know, things like that. Strip your patient, put them in a them bird suit. If they've never in a them bird suit from before, get them in their gowns and, you know, just always be anticipating the worst. All right. In the event that things, you know, gets worse. That's all. All right. What is the complication that a nurse, which complication is the nurse most concerned about in a client with hypertension? So a patient that has hypertension, what is a complication that you are concerned about? So stand them up. Okay. I want to really stand them up in a Lotus. I won't. So if a patient that has hypertension, what are some complications of hypertension that you are concerned about? Orthostatic hypotension. Brain bleeding. Okay, yes. So Lotus says brain bleeding. So stroke, all right. So which complication is the nurse most concerned about in a client with hypertension? You're thinking about A, osteoporosis, B, stroke, C, peptic ulcer disease, D, appendicitis. All right, so the answer is definitely your brain bleed, your risk for stroke. All right, your risk for stroke, MI, heart disease, you know, heart failure. So you always want to be looking out for that, and that's why I say always go ahead. If the blood pressure gets so high, get the patient in the bird suit. You understand? Get the patient, you know, in their gown so you can have access to their chest. You know, get their IVs, their 2 large bore IVs working. So in the event that the blood pressure is just too high and they start having a brain bleed because of that, you can always have enough room to work with in terms of the chest. You have really good IVs that is so close to the heart and you get things going, you know, real nice. All right, not a problem, Island Girl. Thank you so much for tuning in. All right, not a problem. All right, so definitely think about that. A client with valve replacement is on a lifelong warfarin. Which teaching is most important for this patient? A. Avoid green leafy vegetables. B. Have INR checks regularly. C. Stop taking the medication if you feel well. D. Take aspirin with warfarin. So a client is on valve replacement. A client with valve replacement is on lifelong warfarin. Which teaching is most important? A. Avoid green leafy vegetables. B. Have INR levels checked regularly. C. Stop taking the medication if you feel well. Or D. Take aspirin with warfarin. So which teaching is most important for this patient? All right, so D, take aspirin with warfarin. You sure? B, Charlene says B, take INR levels check. Have INR levels checked regularly. A, okay, avoid green leafy vegetables. All right, so let's go with the elimination process. So take aspirin with warfarin. So this patient is on lifelong warfarin, which is, you know, a blood thinner. And we know that aspirin is an NSAID. You're going to be at risk for bleeding. So that one is definitely out, Dorian. All right. Then stop taking the medication if you feel well. No. The patient is always going to need that warfarin, that blood thinner. All right. So that one is out. Avoid green leafy vegetables. Have INR levels checked regularly. Between the two of those, all right, you know, definitely we need to cut down on the green leafy vegetables, all right? But between the avoid green leafy vegetables and having the INR levels checked regularly, which teaching is most important for this patient? Because, you know, they can eat the green leafy vegetables and we can always adjust their warfarin, you know, their numbers, depending on, you know, how much they're eating. But of the two of them, the one that is going to be very, very important is the INR. All right. The INR is going to be the one that is very, very important for this patient. All right. Because they want to make sure that they're meeting their therapeutic levels. All right. In terms of anticoagulation. All right. You still want to encourage them to be eating too much green leafy vegetables. But, you know, sometimes, a lot of times probably the patients still do end up eating, but at least if you have an idea of what their numbers are looking like, then you can always go ahead and adjust their warfarin when they're home. So if they're getting their weekly, you know, warfarin levels checked, then they can always adjust it based on what the numbers are. All right. So the one that is going to be most important is going to be the INR levels. We want to get that checked regularly. All right. Which finding in a peripheral arterial disease client requires immediate provider notification? So you have a patient that has peripheral arterial disease. All right. Which finding requires immediate provider notification? Is it A, intermittent claudication, B, diminished pedal pulse, C, sudden cold pale extremity with pain, or D, delayed capillary refill? So you have a patient that has PAD. Which of these findings requires immediate provider notification? Is it A, intermittent claudication, B, diminished pedal pulses, C, sudden cold pale extremity with pain, or D, delayed capillary refill? Which of those require you to drop everything and run to the phone and say, hey doc, yeah, this is going on? C, definitely. All right, so the patient that has sudden cold, pale extremity with pain, you're thinking about an arterial occlusion. So definitely you want to go ahead and let the doctor know Intermittent claudication, are you expecting that with PAD? Intermittent claudication, where you have, you know, you're walking, the pain is there. Once you rest, you tend to have relief. You're expecting that definitely. Hi, Abby. The legs, the diminished pedal pulses, are you expecting to have that? Yes. All right, you're gonna be having that. The delayed capillary refill is gonna be there. But the one that is going to be very concerning is when you have that sudden cold, pale extremity with pain, all right? There is some form of arterial occlusion going on. So you want to go ahead and let the doctor know, all right? Yes, Lotus, C, sudden cold, pale extremity with pain, all right? So you have a client with a suspected myocardial infarction that has a troponin level of 3.5, all right? The normal is going to be less than 0.04, all right? The nurse should, A, repeat the test in 12 hours, B, notify the provider immediately, C, reassure the client it is normal, or D, start chest physiotherapy. So you have a client that has a myocardial infarction, and the troponin is 3.5. We know that the troponin should be less than 0.04, all right? The nurse should A, repeat the test in 12 hours, B, notify the provider immediately, C, reassure the client it is normal, or D, start chest physiotherapy. B, okay? So notify the provider immediately, all right? Because what are you thinking? So what are you thinking that is going on? Why you want to notify the provider immediately? Heart attack, yes. So the patient is having some injury there. So you realize that the troponin is elevated. So you want to let the doctor know. All right. So will you be repeating this test in 12 hours? Or what is the guideline regarding getting your repeat on your troponins? No, shorter. Okay, yes. All right, so definitely you'll go ahead and get your troponin. At the time when they get into the hospital, 1 hour later, sometimes 3 hours, depending on the, you know, the orders. 1 hour, 3 hours, 6 hours, they'll do serial troponin levels, all right, to see if there's any changes. What if you do the troponin at 3 hours and you realize that, you know, the troponin level is now at the troponin is now at let's say 2. Is that a good thing or a bad thing? So it was at 3 and now it is at 2. 3 hours later, it's at 2. Is that a good thing or a bad thing for the patient? It's a good thing. Okay. All right. Nice. And still, it's still bad. Still bad. Okay, but still bad but good. You know, because you still want it to be less than but the fact that the number is dropping, you know, the injury is not getting worse. If you do it at 3 hours or 1 hour and then you realize the troponin is in like the 30s, you know, then you know that, yes, something really, really bad is going on with that patient. All right, so you want to go ahead and keep a closer eye and probably start this patient on some blood thinner, depending on what is going on in terms of the orders and what the patient was already on. But definitely you want to be watching that patient, making sure that they're getting their pain medication, things like those. All right, and do their serial troponin levels. All right. Reassure the client it is normal. Will you reassure this client to tell them that, you know, yes, it's still high? Will you be reassuring that this patient, that their troponin that is 3.9 is normal? Will you be saying, no, well, you know, your troponin is only 3. It's only 3. Nothing to worry about. Yes, no. All right. What about the chest physiotherapy? Would it be like, okay, then let's get your chest physiotherapy going? Will you start the patient on chest physiotherapy at that time? No, you wouldn't start a patient on any chest physiotherapy at that time. All right. All right. Okay. So, me not have no work morning, you know. So, I don't have any work in the, well, I have my hair to pull down tomorrow. But apart from that, so, you know, I have 100 questions. I don't even know where I'm at in terms of the 100. Oh, this is the final set. So this is the final set of 25. All right. So, but I'm just saying, you know. So we have maternity, pediatric psych, and some delegation priority questions here. So we have 25 of them. So stick around. All right. A newborn with congenital heart defect has cyanosis when crying. All right. Which condition is this most likely? Is it A, patent ductus arteriosus, B, tetralogy of Fallot, C, atrial septal defect, D, ventricular septal defect? TOF, Kerry says TOF, which is tetralogy of Fallot. Do we have anybody else? Do you have any peds nurse here? Okay. All right. So we're going to have to read on those. So tetralogy of Fallot causes text spells with cyanosis during feeding and crying. All right. So let's go. I didn't look up that one. So with patent ductus arteriosus is when you have, all right, so just think of it, patent ductus is when you have the opening between the aorta and the pulmonary artery that is abnormal. All right, so hold on. Patent ductus arteriosus is an opening between the aorta and the pulmonary artery that is normal in fetus but should be closed shortly after birth, where it remains open and allows too much blood flow to the lungs. It can lead to breathing problems, heart disease, and poor growth, and diagnosed by a doctor hearing a heart murmur, with treatment including medications, catheter-based procedures, or surgeries. All right. So that is patent ductus arteriosus. All right. So you have the opening between the aorta and the pulmonary artery. Pad isn't closed after birth. Yes. Okay. All right. And it is not, it remains open. And as a result, it's, you know, you have too much blood flow to the lungs. All right. And then you have tetralogy of Fallot, which is the one that has the, you know, the defect that has the cyanosis there when they're crying. Let me look up the official. All right. So it is a rare heart condition that is present at birth. It means it's congenital heart defect. A baby born with condition has 4 different heart problems. All right. So the condition causes altered blood flow through the heart and to the rest of the body. Babies with tetralogy of Fallot often have blue or gray skin color due to low oxygen levels. All right. And then we talk about atrial septal defect, ventricular septal defect. All right. So tetralogy of Fallot causes text spells with cyanosis during crying and feeding. All right. The nurses teaching parents of a child with Kawasaki disease. Which statement indicates correct understanding? A, aspirin is avoided at all costs. B, we must follow up for possible coronary aneurysms. C, this condition does not affect the heart. D, our child can stop all meds when fever goes away. So the nurse is teaching parents of a child with Kawasaki disease. Which statement indicates understanding? A, aspirin is avoided at all costs. B, we must follow up with possible coronary aneurysm or follow up for possible coronary aneurysm. C, this condition does not affect the heart. Or D, our child can stop all medicines when fever goes away. Oh, Kawasaki was the condition that has the strawberry tongue. Is that one? I've seen that only once. Let's see. if that's it. Okay. So with Kawasaki, they have the red irritated eyes, red cracked lips, and strawberry tongue. They might have the rash, redness, swelling of the feet and hands, swollen lymph nodes in the neck, and they might have the fever. So it's a serious illness, also known as mucocutaneous lymph node syndrome, that causes inflammation of blood vessels. Yes, with fever. All right. Mainly affecting children under 5. Key symptoms include a prolonged fever, at least 5 days, rash, swollen hands and feet, red eyes and lips, and swollen neck or glands. While the cause is unknown, it's believed to be an overactive immune response to an infection in genetically predisposed children and is not contagious. Early treatment with IV, immunoglobulin, and aspirin is crucial to prevent potentially dangerous heart complications like coronary artery aneurysms. All right, so the nurse is teaching parents of a child with Kawasaki, which statement indicates correct and understanding. A, aspirin is avoided at all costs. B, we must follow up for possible coronary aneurysms. C, this condition does not affect the heart. D, our child can stop all medications when fever goes away. So the answer is the one that they must follow up for possible coronary aneurysm. All right. Aspirin is not avoided at all costs. All right. That's what I saw something with the aspirin. Where did I read that? Yeah, the aspirin is very important. So aspirin is crucial to prevent potentially dangerous heart complications. All right. So they must follow up for the possible coronary aneurysm. Our child can stop all medications when fever goes away. That's a no-no. The condition does not affect the heart. It does. And aspirin is not avoided. All right. So Kawasaki disease can cause coronary artery aneurysms and follow-up is needed. All right. So Charlene, you said C, this condition does not affect the heart. It does affect the heart. All right. So that's why they need to do the follow-up with the specialist for possible coronary aneurysms. All right. All right. Which nursing action is priority for an infant with heart failure? A, encourage frequent long feedings. B, provide oxygen and small frequent meals or feeds. C, place the infant in a flat position or flat bed. D, restrict rest periods. So which nursing action is priority for an infant with heart failure? A, encourage frequent long feedings. B, provide oxygen and small frequent meals. C, place the infant flat in bed. Or D, restrict rest periods. B, provide oxygen and small frequent meals. B, yes, using the ABC rule. Okay. All right. But also, like, even though you're using the ABC rule and you want to give the patient, the oxygen, why you want to do the small frequent meals with the babies? C or D? It's actually B. Provide oxygen and small frequent meals. All right. So just remember, prevent vomiting. Okay, because they can't breathe. Okay. But what about, the cardiac, avoid aspiration. What about the cardiac workload? What about the baby breathing, sucking, and you have the heart failure? So yes. All right, so you want to decrease the amount. So you do the small frequent meals because you want to decrease that cardiac workload. All right, remember they have the heart failure. They're not that developed and all of those things. So too much strain on the heart, you want to avoid that. All right, to avoid overfeeding and workload, definitely. All right, so small frequent meals reduces fatigue and the oxygen decreases the cardiac workload. All right. So definitely do that. You want to restrict rest periods. Would you restrict their rest periods? No. They're going to need it. You understand? Especially if baby cry. Oh, Lord. You don't want them to cry too much because then, they'll be working too hard. You understand? So don't get them too upset. Because when them start cry, it's like there's no stopping to this thing. All right. Place the infant flat in bed. No, it's the same thing for adults. You want to put them in a semi-forward position because you want to have adequate, expansion of that lungs. All right. And encourage frequent long feedings. No, you want to do small, short feed. You want to do short periods. Oh, cancer. All right. And you want to do frequent, small feedings, not long feedings. Because imagine you have a patient, a baby, especially the ones that are of a diabetic mother, those babies, they will be sucking on that bottle, but you have to remember that they're not thinking, you understand? So even when they're, they're dying, they need a little oxygen, them still hold on to the bottle and suck. So you want to kind of, break up that little thing there and making sure that they're getting enough oxygen in. Because if you don't tell them to breathe, if you don't tickle them, if you don't stimulate them, probably they don't breathe, you understand? So it's the same thing. Once you put the bottle in their mouth, they will be just there, just sucking, and there's no end to it. You understand? Working on the poor baby. So make sure you do small, frequent meals with this baby to prevent fatigue and all. All right. A child with rheumatic fever is at greatest risk for long-term damage to which structure? All right. So you have a baby that has rheumatic fever. They're at higher risk for what in terms of long-term damage? Is it mitral valve that is going to be damaged, the tricuspid valve, the pulmonary valve, or the aorta? So a child with rheumatic fever is at greatest risk for long-term damage to which structure in the heart? Is it the mitral valve, the tricuspid valve, pulmonary valve, or the aorta? Hi. A, D, so we have mitral, we have aorta, okay. All right, so and pulmonary, so the answer is actually the mitral, A. All right, so rheumatic fever most commonly damages the mitral valve. All right, so that's the one that they have. All right, a pregnant client develops preeclampsia with severe hypertension. Which drug is most likely prescribed? So you have a patient that develops preeclampsia with severe hypertension. Which drug is most likely prescribed? Is it A, an ACE inhibitor, B, magnesium sulfate, C, warfarin, or D, furosemide? Notice said, oh, the pulmonary muscle relaxer. Okay, so which one? So ACE inhibitor A, magnesium sulfate, warfarin, or furosemide. So you have a patient that develops preeclampsia who has severe hypertension. Which drug is most likely prescribed? So Kerry says magnesium sulfate. Why are you going to give the patient magnesium sulfate, Kerry? Why do you want to give this patient magnesium sulfate? Why do you want to give this patient magnesium? Hi, Troy. Welcome. Lotus says C. C is warfarin, Lotus. So the answers are A, ACE inhibitors, B, magnesium sulfate, C, warfarin, D, furosemide. So this patient is pregnant and the patient develops preeclampsia with severe hypertension. Which drug is most likely prescribed? So Lotus says D, furosemide. All right, so ACE inhibitors is what? So prevent seizures in severe preeclampsia. Okay, yes. All right, so B, magnesium sulfate. So you're going to be giving the magnesium because this patient has severe hypertension. So the patient is heading into what direction? The direction of eclampsia. All right. So you want to go ahead and start giving the patient medications that is going to help with the seizure, help with that relaxation of that, the abdomen. Yes. All right, the uterus there. So definitely go ahead and start the patient on the magnesium. All right. So for example, the patient is, patient is preeclamptic, but the patient now start have seizure. Which direction the patient is? What's the diagnosis now for this patient? Are we still in the, oh, the answer is the magnesium sulfate. So the answer is the magnesium sulfate. So the patient starts having seizure now. So the patient's blood pressure is high. The patient is, was diagnosed with preeclampsia, but the patient start have seizure in front of you. All right. All right. Is the patient still preeclamptic, or what are we thinking? Yes, you were, Lotus. Yes, you were with the muscle relaxer. Yes, so the patient is now eclamptic. All right. What are we planning on doing with this patient? Are we going to get this patient the seizure medication and just say, okay, then, ma'am, we're going to wait until, 2 more days. Doctor says 2 more days before you deliver. Are we going to be waiting the 2 days before we deliver? Or what are we planning on doing with this patient? Deliver ASAP, definitely. Do your seizure precautions and you get that patient to the operating room to take out that little tiny tot induction. Definitely bring the patient to the, to the emergency, not the emergency room, to the OR. All right, so the patient is gonna get emergency C-section to get rid of that. Not really get rid of that baby, but yeah, man, get out that baby so the seizure, her risk for those seizure can actually stop. All right, so that is the end goal. All right, so magnesium sulfate prevents seizures. ACE inhibitors and warfarin are contraindicated in pregnancy. All right, it's contraindicated in pregnancy because remember, warfarin is a blood thinner. All right, so definitely you don't want to be giving that to a pregnant woman. All right, because then you're going to be putting that patient for, at risk for bleeding. Furosemide is your loop diuretic, your ACE inhibitors. You don't want to be giving them that either. All right, so those are contraindicated. So preeclampsia. So what are some of the, the things that you'll be looking out for apart from the blood pressure? What are other things that you'll be looking out for with a patient that has, preeclampsia? So the patient is coming into you every week and, you do your regular routine tests. What are some of the things you're looking for with your preeclampsia patient? Yes, swelling. Swelling where? In the head, the eyes, where? General swelling, bleeding, okay. Coldness, blood clots, feet, okay. All right, let's try to narrow it down to the preeclampsia. So we see legs, feet. I guess we're talking about the swelling. What are some of the things that we're looking for when you talk about preeclampsia? So we say swelling. Okay. What are we looking for? When we send the patient to go and get the urine, what are we looking for in the urine? Are we looking for anything? Severe fever, protein, yes. So the patient has severe fever. What are we thinking about? Protein, yes. Fluid retention, definitely, so you're looking at your protein, you're looking at your fluid retention, your pedal edema, all right, your blood pressure. Those are things that you definitely want to be looking for when you have your patients coming in. So I know a lot of times we'll probably say, oh, why this doctor so annoying? Every day them come there ordering, urine tests. Yeah, man, they might check for your preeclampsia. They're trying to prevent you from getting to that phase. You understand? Or get the patients to that phase. So always go ahead and be looking out for those things. All right. A woman with a history of mitral valve disease should be monitored for A, pulmonary edema, B, osteoporosis, C, hypotension, D, liver disease. So you have a patient with a pregnant woman with history of mitral valve disease, which so a pregnant woman with a history of mitral valve disease should be monitored for A, pulmonary edema, B, osteoporosis, C, hypotension, or D, liver disease. So Kerry says A, pulmonary edema. Charlene says C, hypotension. Okay, all right. So a pregnant woman with a history of mitral valve disease should be monitored for AACA. All right, so pulmonary edema is correct. And why you're monitoring that patient for, pulmonary edema? So if the patient has mitral valve disease, why are you concerned about pulmonary edema for that patient? Fluid built up, yes, all right. So definitely, because you have that increase in the blood volume with pregnancy and then you already have a mitral valve that is not working properly, you're going to have pulmonary edema taking place. The heart is overload. Yes, so you want to be monitoring that patient for that. All right. Will you be concerned about the patient for osteoporosis? Who is at risk for osteoporosis? What patients would you be monitoring for osteoporosis? Low calcium, older patient. Yeah, your patient in menopause, anemia. Okay. All right. So all of those patients. What about your liver disease? Who would you be concerned about with your liver disease? Sickle cell patients. Who would you be concerned about with your liver disease? Hepatitis patients, your diabetic patients. Hepatitis, yes. And your alcoholics, your patients who have, who are on their cholesterol medication. All right, remember your cirrhosis patients, those patients. All right. All right. Which finding in a 5-year-old child with congenital heart disease requires intervention, urgent intervention? So you have a 5-year-old child with congenital heart disease. Which patient requires urgent, or which finding requires urgent intervention? A, clubbing of the fingers. B, squatting after play. C, oxygen saturation of 75. Mild tachycardia and with exertion. So which finding in a 5-year-old with congenital heart disease requires urgent intervention? A, clubbing of the fingers. B, squatting after playing. C, oxygen saturation of 75, or D, mild tachycardia with exertion. That was a giveaway. Yeah, that was a giveaway. Yeah, the sat of 75, the sat of 70. Charlene says D, mild tachycardia with exertion. What about the oxygen saturation though, Charlene? What's the normal oxygen saturation? What's the normal oxygen saturation? No problem. But what's the normal oxygen saturation though? 95 to 100. Yeah. All right. So this one says oxygen saturation of 75%. That is like super, super, super low. All right. So definitely you want to deal with that one. That requires immediate, action, because that is like critical for that patient. All right. The nurse is caring for the child who squats frequently after running. What is the best explanation for this patient? Why is this patient squatting? So the patient just ran. The patient has congenital heart failure or heart disease. And every time the patient runs, the patient squats. Why is the patient squatting? For oxygen. Okay. All right. All right. So squatting increases systemic vascular resistance, improving oxygen. So it increases, or relieves right to left shunting in tetralogy of Fallot. Catching a breath, oxygen for expansion. Okay. All right. So squatting increases systemic vascular resistance, improving oxygen. So I guess it's common in the patients with tetralogy of Fallot. All right. It relieves right to left shunting. All right. In terms of that flow. All right. Which finding in a child with coarctation of the aorta is expected? What is coarctation of the aorta? What is that? What is coarctation? All right, so coarctation of the aorta is a birth defect where the aorta, it's a condition of the tetralogy of Fallot, okay, is a birth defect where the aorta, the body's main artery, is narrowed, obstructing blood flow to the lower body and increasing pressure in the upper body. This critical heart defect is usually diagnosed after birth when symptoms like high blood pressure in the arms and weaker pulses in the legs appear. Causes often involve unknown genetic or environmental factors and the abnormal closure of the fetal blood vessel after ductus arteriosus. All right, treatment involves surgery to remove the narrowed section or balloon dilation and stenting to widen the aorta. All right, so there is a significant difference in the blood pressure. So you might have blood pressure in the arms is higher and it's weaker in the legs. All right. So coarctation causes increased upper body blood pressure and decreased lower body blood pressure. So for these patients, you want to make sure that you're checking on all the limbs, their blood pressure. All right. So the finding that is expected is bounding pulses in arms, weak pulses in legs. All right. Yeah, so bounding pulses in the arms and weak pulses in the legs. Which medication is contraindicated in pregnancy due to a risk of fetal cardiac defects? A, beta blockers, B, ACE inhibitors, C, digoxin, or D, heparin. So which medication is contraindicated in pregnancy due to a risk of fetal cardiac defects? A, beta blockers, B, ACE inhibitors, C, digoxin, D, heparin. Dorian says B, ACE inhibitors. Do we have anybody else? So which medication is contraindicated in pregnancy due to risk of fetal cardiac defects? The answer is actually B, the ACE inhibitors. It says ACE inhibitors are teratogenic. Digoxin and heparin are safe in pregnancy. So Charlene said C, digoxin. So digoxin and heparin are safe in pregnancy. All right, but ACE inhibitors are teratogenic. So that should be avoided because of the risk for fetal cardiac defects. All right. A child is diagnosed with rheumatic fever. The nurse expects which medication? A, aspirin only. B, long-term penicillin prophylaxis. C, antivirals. D, antifungals. So you have a child that is diagnosed with rheumatic fever. The nurse is expecting which medication? A, aspirin only. B, long-term penicillin prophylaxis. C, antivirals. And D, antifungals. All right, so B, which is a long-term penicillin, yes, because they want to help with preventing any recurrent streptococcal infection there. All right, so you want to go ahead and get them on those penicillin prophylaxis therapy. All right. A psychiatric patient with severe anxiety develops chest pain. What is the priority action for this patient? All right, so a psychiatric patient with severe anxiety develops chest pain. What is priority? A, provide relaxation techniques. B, give prescribed anti-anxiety medication. C, assess and treat as possible cardiac chest pain. D, reassure the patient it is only anxiety. So what would you do for this patient? A, provide relaxation techniques. B, give prescribed anti-anxiety medication. C, assess and treat as possible cardiac chest pain. And D, reassure the client it is only anxiety. So C, B. Okay, so the answer is actually C, assess and treat as possible cardiac chest pain. Always remember, in the real world, in the real world and the textbook world, All right, whatever is, always think about, anything that is detrimental, life-threatening for the patient. All right. So even though we know that a lot of times patients might come in and they say, oh, I'm having chest pain today, and they come back tomorrow and the same chest pain, and sometimes we realize that the doctors will be doing the same workup. Yes, because at the end of the day, you still want to make sure, you're ruling out certain things. All right. So if the patient says chest pain, it's chest pain until proven otherwise. All right. So they're having chest pain today, tomorrow again, and come back on chest pain. And the next day, yes, it's chest pain. So you always want to rule it out, because the one thing you don't want is to have a patient reporting chest pain, and the one day that you never work up the patient for chest pain, it's a true cardiac event. All right. So always go ahead, assess and treat as a possible cardiac chest pain, and then from there. Provide relaxation techniques is going to be a part of it. Giving their anti-anxiety medication is also going to help. All right, reassuring the patient is going to help. But the priority thing for that patient, once they utter the word chest pain, always think of, working up that patient. If it's the same thing, once they say, oh, I feel like I want to die, always think about safety. All right, so it's the same thing. Don't assume that it's just anxiety. Always think that it's something bigger than anxiety. All right, and then from there. Which task can be safely delegated to a nursing assistant for client with heart failure? All right, is it A, teaching about low sodium diet, B, assessing lung sounds, C, measuring daily weight, D, adjusting oxygen flow rate? So which task can be safely delegated to a nursing assistant for a client with heart failure? CC, okay, measuring daily weight. All right, so which task can be safely delegated to a nursing assistant for a patient with heart failure? So you must know the rules, the responsibility of the, your support staff, all right, or your team members when you're delegating. So C is definitely measuring daily weight. But you could just go and tell him, say, look, John, just go adjust the oxygen flow rate there for me. Just put it down to 6. Why you never just tell the nursing assistant to do that? Why? Why you don't just, tell him to go ahead and do that? Or you say, go and tell the patient not to eat any eat any, high salt diet, or anything that is too sugary, things like that. Why you can't just, yes, it's not in their scope of practice. So anything that has to do with teaching, assessing, adjusting, making changes to, like, their medication, that is going to be the responsibility of the RN. All right. So even though a lot of times we might say, yeah, go and do this and whatever, it's not the right thing. All right. It's not the right thing. Sometimes we might be running, like we're running low on staff, and we end up saying, oh, the nurse or the CNA or whoever is there, and we say, hey, just turn on that and whatever. Really and truly, is not that person supposed to actually be turning it down. We're the one that's supposed to be adjusting, the flow rate and everything. All right. So anything that has to do with teaching, assessing, educating, initial assessment, that's the responsibility for the RN. All right. Everything else you can delegate once the patient is stable. You can always, or if it is reassessment, things like that, then you can always delegate to your support staff. All right. So UAPs can measure or report weights. Teaching and assessment remains the primary duties of your RN. All right. Hey, Jacinth, welcome, welcome. All right, so definitely do that. All right. The nurse is assigning patients. Which client is best for your LPN? All right. Is it A, new admission with chest pain? B, post-cardiac catheterization patient with absent pedal pulses? C, stable patient with hypertension needing oral medications? Or D, client awaiting discharge after MI with education needs? So you have all of these 4 patients, but you say, no, so I'm tired. I need somebody to help me. Which of these patients you're going to delegate to your LPN? Is it your new admission with chest pain? Is it your post-cardiac catheterization patient with absent pedal pulses? Is it a stable patient with hypertension needing oral medication? Or the client awaiting discharge after MI with your education needs? Lotus says D, which is the client awaiting discharge after MI with education needs. Who do we say over here? I need 1 person. 2 persons. And thank you everyone for tuning in. All right, remember to go ahead and tap up the live and follow. All right, you can also find the full length of the live on YT. All right, YouTube, definitely go over there. Subscribe to the page. It's ThinkNursing, one word. So definitely do that. All right. So Kerry says C. All right, stable patient with hypertension needing oral medications. All right, and always be look at the words that they use. They say stable. So always look at it. Sometimes the words are so simple, but yes, they're not making it that complicated. All right. So just look at the words and read through and always think of the perfect environment. All right. You're never short staff. You're never running low on anything. It's always there. No other patient not in the room. No other patient not dying. You understand? You're just focusing on that one patient. So stable patient with the hypertension needing oral medication is appropriate for your LPN. New admission with chest pain, new admission, responsibility of your RN. All right. Anything that has new admission, initial assessment, things like that. If it was like, even if it was if it's, for example, it was an existing patient that has new onset chest pain, that is still going to be the primary responsibility of, your RN. Just because it's the new onset chest pain, you're going to have to go and assess the patient. All right. The post-cardiac catheterization patient with absent pedal pulses, post-cardiac catheterization patient, you have to go and assess the patient, all right? And then the absent pulses, you have to assess the patient. You have to assess the patient. So definitely that is going to be your RN as well. Stable client with hypertension, needing oral medications, that is something that your LPN can do. Client awaiting discharge after MI with education needs, anything that has to do with educating the patient, that is going to be the primary responsibility of the nurse. If it was a patient that is, let's say that the patient has already gotten their discharge instruction and wanting some more information, re-education, things like that, then you can say, all right, then you can have your LPN go over and just explain a few things regarding diet, exercise, things like those. But the initial education, discharge, all of those teachings are going to be the primary responsibility of your RN. All right. So the LPNs can care for stable patients with predictable outcomes. Which action by a new nurse caring for a post-MI patient requires intervention? Is it A, placing the client on continuous cardiac monitoring? B, administering oxygen at 2 liters via the nasal cannula? C, ambulating the patient immediately after admission? Or D, monitoring troponin levels? So which action by a new nurse caring for a post-MI patient requires intervention? Is it A, placing the patient on continuous cardiac monitoring? Is it B, administering oxygen at 2 liters via nasal cannula? Is it ambulating the patient immediately after admission? Or D, monitoring troponin levels? So we have C, which is ambulating the patient immediately after admission. Okay. All right. So we have C, and then we have somebody that says D, monitoring troponin levels. All right. So the answer is actually C, ambulating the patient immediately after admission. Remember, this patient is a post-MI patient. All right. This patient is a post-MI patient. So you don't want to be having this patient start with ambulation, immediately after. That is going to be a little bit unsafe for that patient. All right. So they need to rest initially, and then, you advance. Eventually, you get back to getting out of bed and all. But for the initial phase, ambulating the patient immediately after ambulation, that requires intervention. All right. Placing the patient on continuous cardiac monitor. Are you going to be doing that? And why? Yes, you definitely want to be doing that. What if this patient's now start, telling you that, oh my word, I'm having some chest pain. Are you going to be concerned about it? Or are you going to be like, you know what, ma'am? The doctor just went and did your cardiac catheterization. It's expected. Well, are you going to be concerned about that chest pain and just tell them, oh no, just relax a little bit, take some deep breaths? You're going to be concerned. Definitely. All right. What are you concerned about? Are you concerned about the fact that there is you know, just the incision site, or what are you concerned about with this patient? Why are you gonna be like going over there and be like, okay, then let me go and call the doctor, let me go ahead and do this? You're thinking about another MI. Yes, because this patient just had surgery, now having chest pain. You're thinking about like a clot or something going on that is causing that. All right. Administering oxygen at 2 liters via nasal cannula. Would you be giving this patient oxygen? 2 liters of oxygen. Would it hurt giving this patient 2 liters of oxygen? Can give the patient a little oxygen. Nothing is wrong with that, you know. It wouldn't hurt, you know. All right, it wouldn't hurt. Monitoring troponin levels. Will you be monitoring the troponin levels for this patient? And would you be expecting the troponin levels to be like high or low? What are your thoughts on that? Which direction? It wouldn't hurt, but if the doctor wants it, definitely. All right. Which direction are you looking for with the troponin levels? Are the troponin levels going to be low, or is it going to be high, or what? So Dorian says, yes, it's going to be low. All right, just think of it that, you know, you already have the heart attack. The numbers are going to eventually be fluctuating, or it's going to be, yeah, it's going to fluctuate. But initially it's going to be high. Just think of it that, you know, you already did have a heart attack, all right? Or whatever is going on. And then the doctor go in there and go play around with, you know, let's just say play around. They do surgery and all of that, you know, stress on the heart. The numbers are going to be elevated, and then eventually it's going to be going down, all right? So it depends on the state of the patient. All right, so it's gonna initially be high, and then it starts, you know, tapering down or dropping in numbers. An immediate intervention. All right, but when you look at the question, you see it says that the patient, which action by the new nurse caring for the post-MI patient requires intervention, is the one that says ambulating the patient immediately after admission. All right, all the others are things that you can do for the patient, but the one that you'll be concerned about is the safety of the patient, which is the ambulation. All right. A client with atrial fibrillation asks why they must take anticoagulants. What are you going to tell them? So somebody says, well, nurse, you know that, you know, my heart rate is just like, you know, the doctor says that it's just doing like this. But the doctor says that I need to take this medication and I don't feel like I need to take it. What is going to be your best response for that patient? Why the patient needs it? Prevent clots. And what we had said earlier, with a patient with atrial fibrillation, they're at highest risk for what kind of clot? What clots are they at highest risk for? Pulmonary embolism. So they're at risk for, you know, they're at risk for pulmonary embolism, MI. But we had said for the, okay. So they're at risk for the embolic, okay, so heart valve clots. All right, so they're at risk for stroke. All right, so that's one thing you definitely want to be monitoring these patients for. All right. So the client, so a client with atrial fibrillation asks why they must take anticoagulants. The best response is A, they help control my heart rate. B, they prevent clots that can lead to stroke. C, they make your blood thinner so you feel better. D, they help your blood pressure stay normal. So which of those is the best response for that patient? Hey, Shelly. B, they help prevent clots that can lead to stroke. B, definitely. They prevent clots that can lead to stroke. They help control your heart rate. So which medication control your heart rate? What class of drug are we looking at that controls the heart rate? Thinking about your beta blockers, your atropine, okay. All right, but we're thinking more about your beta blockers, all right. They make your blood thinner so you feel good. It's gonna make your blood thinner. Eventually, make you feel good, I guess. Digoxin, definitely. They help your blood pressure stay normal. Does this really help with the blood pressure? Does this help with your blood pressure staying normal? No. All right. So definitely it helps with preventing clots that can lead to stroke. So anticoagulants reduces the risk of embolic stroke in atrial fibrillation. All right. So definitely encourage them to take that medication. Anti-failure. Okay. I'm from Jamaica. Laticab. All right. Which client should the nurse see first after change of shift? See first after change of shift. So you have these 4 patients. Let's see you alone. So you have these 4 patients. You just got report. Which of the patients you're going to run to first? Sorry. A client with a blood pressure of 150/90 and no symptoms. B, a client with chest pain radiating to the left arm, A smalls. C, client with chronic atrial fibrillation with a heart rate of 92. Or D, a client with heart failure who gained 2 pounds in 3 days. All right, so you have you just got report, and the nurse tells you these are your patient. Who are you going to be rushing to see first? A client with a blood pressure of 150/90 with no symptoms. B, a client with chest pain radiating to the left arm. C, a client with chronic atrial fibrillation with a heart rate of 92. Or D, a client with heart failure who gained 2 pounds in 3 days. Chest pain could mean cardiac arrest, Lotus, chest pain, heart attack, MI. Definitely. All right, so you definitely want to look at your chest pain because of the possible MI, so that patient is priority. All right. But what about the patient with, chronic atrial fibrillation with the heart rate doing this? Why you want to run to that patient? Like, if your heart is doing something like this, fibrillating like that, be concerned about that patient. You're not concerned about that patient? Huh? Or the heart rate now really so none. Yeah, me not concerned either. Heart rate is fine. Heart rate is normal. All right, it's normal for the fibrillation. So patient will survive. Blood pressure of 150/90, no symptoms. Can still wait. Heart failure patient who gained 2 pounds in three days. 2 pounds is not so bad. 2 pounds not so bad. It sounds like a lot, but 2 pounds is not so bad. That patient can still wait as well. All right. So most of these are like chronic. But that acute chest pain or that chest pain radiating to the left arm, you always want to go ahead and check on that patient, and then from there. All right. A client with aortic stenosis reports dizziness. That is expected. Yes. A client with aortic stenosis reports dizziness and syncope. The nurse knows this is due to A, increased preload, B, decreased cardiac output, C, fluid overload, or D, hypertension. So a client with aortic stenosis reports dizziness and syncope. The nurse knows this is due to A, increased preload, B, decreased cardiac output, C, fluid overload, and D, hypertension. So Kerry says B, Champagne says B, which is decreased cardiac output. Okay. I think Lotus says hypertension, which is D. Okay. So the answer is actually B. All right. The decreased cardiac output. All right. So decreased cardiac output. So you have narrowed valves, reduces cardiac output, leading to syncope and dizziness. All right. So the patient has aortic stenosis and is reporting dizziness and syncope. The nurse knows this is due to decreased cardiac output because of the narrowed valves. It reduces cardiac output and it causes the patient to have, the syncope and the dizziness. Yes, decreased cardiac output, Shelly. All right. In prioritizing care, which client is most unstable? So is it A, post-op cabbage patient with a chest tube drainage of 60 mils per 60 mils per hour? Is it B, a client with a blood pressure of 88/50 with a MAP of 60? Is it C, a client with atrial fibrillation on warfarin and INR of 2.5? Is it D, a client with hypertension and a blood pressure of 150/98? So in prioritizing your care, which client is most unstable? So you come in to work and you have your report and these are your 4 patients. Which one is unstable? Which one are you going to go to first? Is it A, the post-cabbage patient with chest tube drainage of 60 mils per hour? Is it B, the client with a blood pressure of 88/50 and a MAP of 60? Is it C, the client with atrial fibrillation on warfarin that has an INR of 2.5? Or D, a client with hypertension that has a blood pressure of 150/98? Who are you going to see first? Kerry says B. Okay, Champagne says 8. I wonder if a B should try right. B. Okay, B. Definitely B. The client with 88/50 and a MAP of 60. All right, why are you concerned about that blood pressure and the MAP? Why are you concerned about that blood pressure? What if the MAP was, well, what are you concerned about with that vitals there? Because you have some patients who the MAP is low. Yes. What is your goal for your MAP? What is a good MAP you're looking for? What if the patient had a blood pressure 88/50, but the MAP was 65, 68? Would you be still concerned about that patient? Would you be still concerned about the patient if the MAP was 88/50 or 65, 70 in terms of MAP? 65 and above, okay. So yes, that's the MAP you're looking for. So if the patient's blood pressure is 88/50, the MAP is 65 or 70, would you be still concerned about that patient? So Justin says yes. Jacob says yes. Okay. All right. Shelly says no. All right. Why no, Shelly? Because I wouldn't be worried about the MAP of, I personally wouldn't be worried about the MAP of, 70. And I would take into consideration other things. Because if the patient is oriented, alert, in terms of mentation, all of that is good. I'm not worry about the MAP of the blood pressure. You understand? Because the MAP is good, meaning that the patient is getting adequate amount of blood flow. So oxygen is going to the heart and everything. So I wouldn't be like, say, worried about that blood pressure anymore because the MAP is still decent. All right. All right. So it depends on other things that are going on. So even though the blood pressure, the 88/50, it can be a case where, the 88/50 can be, so for example, the patient is normally on the lower side. You understand? And it's their normal, and it is their normal, then I wouldn't be concerned about it. You understand? Because if the MAP is a little bit high, then the patient is perfusing well. It's not having any, the patient is not having any issues with, the MAP being so low, then I wouldn't be concerned about it. I would keep on monitoring to make sure that the trends are remaining the same. But you understand? But otherwise, extenuating conditions. Yes, definitely. All right. So that patient would have been priority just because the MAP is low at 60. All right, you want the MAP to be a little bit higher, and then from there, the client with atrial fibrillation on warfarin, the INR is 2.5, so that is pretty stable for that patient there. All right, the client with hypertension, blood pressure is 150/98, not dying, still can look at somebody else in the meantime. Post-op cabbage with a chest tube drainage of 60 mils per hour, not so bad. But I would probably go to the hypertensive patient with the MAP of 60. Then I would go to the post-CABG patient, then the hypertensive, then the atrial fibrillation. That's the direction I would go with that patient load. All right, so hypotension on the map of 60 indicate poor perfusion and that patient is unstable. All right, and then from there. Which discharge instruction is most important for a client with heart failure? So A, report weight gain of 2 to 3 pounds in a day. B, exercise until you feel short. Exercise until you feel short of breath. C, increase fluid intake daily. Or D, stop your medications if you feel better. All right, so which discharge instruction is most important for a client with heart failure? So report weight gain of 2 to 3 pounds in a day. B, exercise until you feel short of breath. C, increase fluid intake daily. Or D, stop your medications if you feel better. Kerry says A, Champagne says A. Report weight gain of 2 to 3 pounds in a day. Definitely. Exercise until you feel short of breath? No. All right. That patient will be waking up, moving. That patient can be moving, them bed linen. They're moving the sheet to cover themselves and feel short of breath. You understand, with their heart failure. They might be getting out of bed and feel short of breath. So exercising until they feel short of breath is something that you don't want to be doing. All right. Increase fluid intake daily. No, they're going to be on some restrictions. They're going to be on fluid restrictions. So you don't want to increase their fluid intake daily, all right? Because it's just going to be worsening their heart failure. Stop your medications if you feel better. No, they'll continue medications. You understand? Because they need it for their heart. So definitely they don't stop. So the sudden weight gain indicates fluid retention. So early sign of worsening heart failure is the increase in the weight. So you want to go ahead and make sure they're monitoring their weight, or if they're on the floor, you will do daily weights on these patients to make sure that, they're not putting on too much. All right. 2 more questions to go. A nurse is floated to the cardiac unit. Which client is safest to assign? All right. So which patient is safest to assign to the plug this in. Ooh. Can't find the hole. No, sir. Where is it? Oh, 1 minute. Other phone battery dying. I'm trying to plug in this phone. Okay. Oh, I forgot to say different charger. Oh, different charger. 5%. Hopefully I finish before 5. When you laugh about Shelly. So why am I not gonna do a gynae? An OB? All right. I have 2 more questions. So nurse is floated to the cardiac unit. Which client is safest to assign? All right. Is it A, a client with unstable angina requiring IV nitroglycerin? B, a client post-cardiac arrest on mechanical ventilation? C, a stable client with controlled hypertension? Or D, a client with new onset chest pain? All right. So you have a nurse that floated to a cardiac unit. Which client is safest to assign to that nurse? A, a client with unstable angina requiring IV nitroglycerin. B, post-cardiac arrest on mechanical ventilation. C, stable client with controlled hypertension. D, client with new onset chest pain. So CC, which is a stable client with controlled hypertension. But even though in the, NCLEX world, does this often happen? Do they normally do that? No, man, them say you're a nurse, no? So, yeah, man, them say you're a nurse, so go and take your cardiac patients. But in the real world, by right, it should be, nurse and nurse. Exactly. You could be a new nurse, they probably give you the same patient. You understand? They tell you, go and get that post, and probably have to be reading at the same time while they're trying to understand what is going on with the patient. But it's not safe, it's not right. You understand? It's supposed to be getting the stable patient when you get on those floor, because you're not familiar with, you know, a lot of the conditions, you know, you're not an expert in that area. It's unfair for you to, even though, you know, managing angina is probably something that you can do because you probably work in the emergency room or you work on other floors that do get it. But, you know, no, it doesn't always happen like that. All right. So even though in the NCLEX world, you should be getting a stable client with a control, you know, controlled hypertension, things like that. When you get out there, it's going to be nurse and nurse. Exactly. All right. So, just, you know, just be mindful. Or when you get on the floor, if you know definitely if it's a area that you're not comfortable with, or the conditions are things that you're not comfortable with, just definitely speak up. You understand? A year license, not only the license, but for the patient as well, in terms of safety. You know, speak up on behalf of the patient as well as yourself. All right. So if you're floated, you're supposed to be getting patients that are stable, predictable, and you know, it's gonna be for the safety of the patient as well as for yourself. Client with unstable angina requiring IV nitroglycerin. You know, most of the time, the nurses on the cardiac floor would have been doing this thing over and over and over every day, titrating the patient on like nitroglycerin. So definitely they will feel a little bit more comfortable doing that, even in them sleep. You understand? So always say, hey nurse, why not you do that one and I'll do, you know. They probably say, yeah, the lazy nurse though, you know, but just always use the word in the interest of the patient, the best interest of the patient, for the safety of the patient, things like that. All right. Client post cardiac arrest on mechanical ventilation, the same thing. Client with new onset chest pain, you're supposed to get manage that one day. You understand? You're supposed to get manage it. But new onset chest pain, cardiac floor, it's the same thing. That's gonna be for the nurse. That is like, you know, full-time or staff there. All right, first of all, no stable patient is on a cardiac unit. Everyone unstable, definitely. C describes a stable client. Yes, a stable client with a controlled chest hypertension. All right, so we need a night. Okay. Which action demonstrates correct understanding of prioritizing using Maslow's hierarchy of needs? A, teaching about diet before assessing chest pain. B, administering oxygen before giving morphine. C, providing discharge instructions before vital signs. Or D, providing or give routine medications before checking for bleeding at cath sites. All right, so which action demonstrates correct understanding of prioritization using Maslow's hierarchy of needs? Is it A, teaching about diet before assessing pain, chest pain? B, administering oxygen before giving morphine? C, providing discharge instructions before vital signs? Or D, give routine medications before checking for bleeding at cath sites? All right. So which action demonstrates the correct understanding of the prioritization using Maslow's? So B, administering oxygen before giving, okay, morphine. Yes. B, yes. All right. All the others, they might go back way. You realize? Yeah, man. So administer your oxygen before giving morphine. All right. Teaching about diet. Oh, okay. I'll be there tomorrow. Thanks though for checking out. All right. So teaching about diet before assessing chest pain, that is, you know, a no. You want to go ahead and find out about the chest pain and then you can teach afterwards, all right? Because remember, what if it's something that is real cardiac? You understand? You want to look at the patient first in terms of their physical needs, safety. All right. Providing discharge instructions before vital signs is the other way. You do your vital signs and then you do your discharge instructions. All right. Because what if you do your discharge instructions and then when you go to do your vital signs, well, you know, you can do your discharge instructions and then, you know, but do your vital signs. If there's anything abnormal, go ahead and address it and then from there, you know. Give routine meds before checking for bleeding at the catheter site. No, because what if one of the medication is like a blood thinner and you go now and give this patient this medication and then the patient is already bleeding out under the sheet? Like, you know, go ahead and do the opposite. Check the bleed the site. Then you can always go ahead and choose what medications they're going to be given. All right. So the priority action here would have been administering oxygen before giving morphine. And why you want to do that? Why you want to administer oxygen before giving morphine? D is tricky because it mentions bleeding, but always remember ABCs. Yes, yes, definitely. Why you want to give oxygen before morphine? Why is that priority? Slow breathing. Okay. All right, so definitely want to get that patient oxygenated, and then, you know, because respiratory depression is something that the morphine slows down your respiratory system, definitely. All right, so you want to just make sure you give that patient a little oxygen before you go ahead and give them that morphine. All right, and then from there. All right, so oxygenation is priority over pain relief and the teaching. All right, so that's that one. All right, and I think that's about 100 questions. All right, so this was all NCLEX related and cardiovascular related questions. So we touched on pharmacology, fundamentals, med-surg, special populations, priority, and the whole 9 yards. All right, so that's about it for today. All right, it was nice having you guys over. All right, it was nice having you guys over here on the live. Never expected it to go to 11 o'clock, but you know, it was nice. I was having fun. You're welcome, Shelly. You're welcome. Not a problem, Carrie. Not a problem. You're welcome. All right, so join me on Thursday again. We'll do another, you know, probably we can probably do a what night you want us to do. Every day I learn something new. Not a problem. So what system you want me to prepare questions regarding? So we can do GI, can do a GI night, or neuro. We can do neuro. They always say start with the hardest one. All right, but so we can probably do GI, or I don't know what system you want me to prep questions for. So all the questions are gonna be surrounding, you know, that system. All right, we can do GI. I don't see anybody saying anything, so we'll do GI on Thursday, and then from there, all right, we can think about. Okay, so Shelly says neuro. All right, so going once, going twice. Oh, so I'm trying to do this just on Tuesdays and Thursdays from 7 o'clock. All right, so on Tuesdays it's supposed to be 7 to 8. Yeah, but you know. On Thursdays we do 7 until, because I don't work on Fridays. So it's gonna be 7 until I finish the questions. So I guess 7 to 11. All right, and then from there, but I do live at 7 o'clock either way. I do pop in live at 7 o'clock either way. And then from there. All right, so I am gonna go to my bed. Oh, I'm gonna wake up in the morning and do my 5:30 Peloton ride. So you can join me at 5:30 as well for Peloton ride. You're welcome, Champagne. Yeah, try to beat off the fat here. Is that fat here? Yeah, man. Go on a bicycle, go ride for 30 minutes and see what I can do. All right, but anyways, enjoy your night. All right, enjoy your night. And I don't know who is doing exams soon, but you know, just continue prepping, reading, study, understand. All right, and then from there. No man with one. What are you talking about, Shelly? You talking about my big belly? Huh? Yeah, man, need to ride off the belly here. So come and join me at 5:30 in the mornings, all right? All right, then well, enjoy your night. All right. And Justin, it's nice seeing you. All right, it's nice seeing you. All right, then later. All right, Shelly Lotus.